your work, for showing up the second day in a row. And today we had some good night's sleep, but still we lived through the tragedy yesterday and now commemorate the memory of those who died.
Дякую, друзі.
Thank you, dear friends. And we really want to get rid of our enemy as soon as possible. So today is the second day. It's going to be quite busy as yesterday. And yesterday we were working really on all the issues like funding, strategic areas, etc. And at first, I would like to voice out some organizational things. We have simultaneous interpretation, so please take some headphones if necessary. And also, I will repeat it in English now, because there are plenty of people listening to us online. Well, they don't need the headphones offered here.
With simultaneous interpretation, so please take a headset and if needed, switch it on and select the appropriate channel. If you need any assistance, please feel free to ask a member of the technical team. Також, друзі, в нас працює QR.
Also, friends, we have a QR code here. You were actively using it yesterday, and thank you so much for that. It's available here at the stage and also at the back side of your badge. If you're with us online, you shall see it on your screen. So just scan it, or you can also go to the website. What's important for us? That you take part in our surveys, polls, and this gives us an understanding whether we speak in a common language or there are huge gaps in our perceptions. And you can ask questions. And those would go to our presenters, and I will pass them on right after the presentations. Speaking about the safety and security, this is one of the algorithms of our life now. If the air raid alert is announced, you can use the shelter. You can go there even if we do not stop the form. It's up to you. We follow all the chats. What's the level of threat? Yesterday we had air raid alerts almost the whole day, but it didn't stop us. Thanks God, everyone's safe and healthy. And I wish that we don't have any air raid alerts today. And for the Russians to die, well, I've mentioned that as well. I'm sorry. Okay, friends, and our second day is dedicated to organizing integrated care for people living with HIV, TB, viral hepatitis, substance use disorders, as well as mental health. The key focus would be ensuring the continuum of pathway regardless of the entry point. And this is the high time to check whether our QR codes are working. Let us start and set out the dynamics. Please scan the QR code, and we have a first question. Please go to the survey category and please listen to the first question. What do you think most frequently complicates exchange of information about the person getting TB, HIV, substance use disorder services between various services and institutions. So, what is the key complication for this person? If to speak about various services and institutions, please select an option that you think is correct. Electronic systems do not provide full data exchange between providers. Information is transmitted too late or not in full. Specialists do not have access to the necessary information. Yet another option, it is not determined or specified who should transmit and update information. And yet another option, some information is still transmitted manually or in hard copies on paper. And the final one, the information obtained is not used to manage a client's pathway and coordinate further assistance. Well, choose the most common reason from the list, and you have 30-40 seconds as always.
Нагадую, потім
Let me remind you that then we will show the results of this very survey in order to understand the average temperature in the ward, as we say. I see half of the room is still sitting in their gadgets, strongly hoping you're not reading the news, but you're still participating in the survey. Please think which options suits your preference, and we will proceed to the next question. Are you ready for the next one? Great. So, choose 3 options and determine their priority, placing them in first, second, or third places. First place has the greatest weight, the second less, and the third the least. So, the question is, what HR and management decisions are necessary for the practical implementation of integrated care? What do you think? Plenty of options again, and you have to rank them first, second, and third. So, options. Training of existing staff to work on integrated pathways, expanding the roles and powers of healthcare workers, introducing changes to internal training, mentoring, and assessment of the quality of teamwork, strengthening the role of nurses in leading and supporting people who get services, integrating psychosocial support skills into the work of healthcare workers, changes in pre- and postgraduate education, expanding the roles and mandates of workers to coordinate care, introducing the role of a pathway coordinator or case manager, strengthening the role of nurses and other team members in support, and integrating psychosocial support into the work of the facility team and partner services. Please vote, ranking what you think fit first, second, and third. From the most important to less important, and we'll check the results. If the results are ready, you can start demonstrating them at our screens. So, what in your opinion contributes to the exchange of information about the person receiving TB, HIV, and addiction services between various services and institutions? So, you believe that the key problem would be electronic systems do not provide full data exchange between providers. I strongly hope this information is useful for you, and I hope there are people who know how to deal with this, how to improve the situation. That's the reason why we have this surveys. Oh, wait, people, I made a terrible mistake. I see the top line and I believe it ranks first, but no. 33% would go to the other statement. I'm very sorry. You believe that the complication would be that the information received is not used to manage a person's pathway and coordinate further assistance. Well, but to be frank, I should tell you that the gap between these two statements would be just 5%. So the electronic systems do not provide full data exchange between providers is also an important reason here. So it was my bad, but still this one ranks second. And what ranks third? 13%. You believe that specialists do not have access to the necessary information. So you see the results of the survey here on the screen. I repeat myself, I strongly hope there are people who know what to do with this information, how to improve the situation. Or maybe this will be an issue for further discussions. And the results of the second question. Okay. What HR and management decisions are necessary for the practical implementation of integrated care? You had to rank it. And now the top line is really the one you think is most important. It's the leading one. Training existing staff to work on integrated pathways. Then strengthening the role of nurses in case management and supporting people, as well as the introduction of the role of a pathway coordinator and case manager. Well, it seems logical. And you are great experts in all this. The results show this. Thank you so much for taking part in the survey. And now we move on to the first session. I would like to remind you that in the course of the session, you can send your questions to the presenters and we will voice them out at the website or the platform. So, cross-cutting issue would be who shall do what not to interrupt the pathway. And today, at this stage, we are going to see people who ensure continuity of care at various levels. They will help us finding answers to the questions. Now we are going to have an opportunity to listen to the presentations of every panelist. Everyone will present short practical experience or pathway. And I would like to remind you that the time limitation is 15 minutes. And if we're within the timing, we will still be answering questions. First, we will consider a pathway through HIV services, from testing to early launch of treatment and long-term adherence. Tatiana Haboret, Senior Advisor for HIV Services, Reach 95 Project, American organization, PAS. Tatiana Haboret, you're welcome. Good morning, dear colleagues, dear participants of the National Forum. So far, I would like to present the experience of Reach 95, high-quality HIV services in Ukrainian healthcare institutions that's funded by the U.S. government and is being implemented by PAS organization. If I may ask, let us have a look at the presentation. Yesterday, we spoke a lot about timeliness of services provision, about continuum of care. And today, I would like to start with a story, with a clinical case that tells us about lost opportunities. We lost an opportunity to set a correct diagnosis. This is a woman, 64, that tells us that HIV epidemics as of today doesn't have any age limits, who resorted to various physicians with various manifestations, symptoms, including those that shall serve the reason to initiate HIV testing. And the first visits happened in 2021, and this woman was coming and visiting various specialists for 4 years. And you can even see the screenshots of diagnosis with which she resorted to specialists. And all of this is an indication for HIV testing, but somehow up to 2025 the testing was not conducted. And I would like to tell you that a way to set the diagnosis was a woman coming to an institution that was part of the project, the one that was introducing innovative approach of assisted self-testing, where they had a specialized department that welcomes patients, and these patients are offered services of assisted self-testing regardless of the risks of the indicator conditions. If a patient gets to this department, physicians will offer the self-testing services. And this being the case, a woman was offered the services. She said yes, and an oral yes was enough because there's a self-testing, and the positive result was obtained. After that, this woman passed through all the algorithm of testing. Following the national algorithm, the diagnosis was confirmed. Unfortunately, it was the 4th stage of HIV infection with a severe immunosuppressive condition, and CD4 cells were soaring. But this woman is on ART today. And we believe this case was really a success to a certain extent. But let us consider what the project is doing, not to have a lot of these clinical cases for the diagnostics of people who live with HIV to take place at an early stage when there are no severe immunosuppression, severe manifestations, and opportunistic infections. The project is operational in 278 institutions of healthcare in 16 project regions of Ukraine. 117 of those are primary healthcare level institutions. Within the framework of the project, we implement 3 modalities of HIV testing. That's health worker initiated one, index testing, and self-testing, supported and without the support of the third party. For the services to be provided in a high quality manner, the project developed a range of tools that were disseminated between project institutions. These were SOPs. Those were consultation cards, counseling cards, motivational counseling cards, then the tools that were identifying which categories of people shall be subjected to testing first and foremost. And these cards are available, these placards are available in our project institutions to help prescribing the services in a timely manner. If we speak about healthcare worker-initiated testing, every project institution has got 3 tests of various manufacturers, not to carry just the screening stage, but in case of the positive result, to conduct the second and third test to verify the diagnosis and issue the first medical certificate with the diagnosis and refer a patient to yet another facility where they've got an ART site for this patient to be enrolled in care and for them to be prescribed ART. And also in every project institution, they've developed and adapted the pathways of patients. In those pathways, there's really the route, the responsible persons identified at every step. And actually, every route of the pathway starts with where to go, in what case. If an institution has got several departments and every department is running the testing, every department will have a separate pathway then. But I would like you to pay attention to those spots where we can lose a patient. And the first potential losing spot would be After the positive screening test, even institution doesn't have an opportunity to conduct the verificational stage. The patient is referred to another facility, and unfortunately, they don't always show up there. For this not to be happening, the project used all the steps possible to avoid this from happening. So every project institution has got 3 tests. Then the second falling out spot would be when the diagnosis is set, the first medical certificate is issued, a patient is referred to yet another facility where there's an ART site for the treatment to be prescribed. And not to have a falling out, we use the social support. We have social work coordinators team who are supporting those patients who need that. And if to speak about figures within the period of our project activities and project institutions, we've tested more than 451,000 people with HIV tests. 5,500 were the new HIV cases, newly identified. I would like to tell you that all the testing results in the project institutions are introduced into the national informational system. Both positive and negative results, findings not to have losses, and for all these findings to be properly registered. The next modality we introduced would be HIV testing, and it's being implemented using several approaches. It could be non-assisted self-testing when a person gets the test and has an opportunity to run it at home in the confidential setting without assistance of a social or medical worker. And this being the case, we disseminate tests for self-testing, and on the basis of each and every project institution, more than 54,000 self-tests were disseminated. And every self-testing device that are given for non-assisted testing has got a sticker with the contact details of social work coordinator, and the person can call this person up for any kind of consultation, and this is an anonymous call. And the person is getting counseling whenever it's needed or whenever it's comfortable for them. And also we have an assisted approach. So far, we've selected 9 healthcare institutions, HCIs, and we've selected several departments. Well, the number of departments vary from 10 to 3 in various HCIs. 4 institutions were involved since the 1st of September 2025, and 5 are operational from May this year. But have a look, within 10 months in 9 HCIs, we ran almost 19,000 assisted self-testings. Well, what do you mean by this? The self-test is being used, but still the healthcare worker is supporting a client, and there's no written consent needed. Just oral consent is sufficient. And it's not part of the national testing algorithm. And we get a reactive test result if we get 2 strips. So we got 282 reactive results. 159 were the newly identified HIV cases. 146 of them got enrolled in care. The next approach would be disseminating self-testing HIV devices through the social media. This is the box. Anyone can order. It will be delivered by the Nova Poshta Postal Service free of charge. For this to happen, it's enough to scan a QR code, participate in a short survey, and order this package. We were developing a few videos to promote this very approach, and one of the videos is available for you today. Let us have a look. What have you got in the bag? Show me. Oh, that's a book. Why do you need it? Well, I use it just to put my phone on it. Then advent calendar, and this is a piece of wood. I just found it and put in my bag. Well, that's nice, but you deprived a bird of a house. This is condom. If you had sex with more than one partner within the recent 12 months, just order the self-testing kit because safe sex is 1+ to your karma. Do you know that you might have plenty of concealed secrets? Well, these videos were quite popular among the key population, among this audience, and they were posted in TikTok, Instagram, etc. So now I would like to proceed to the next modality, and that's the index testing. Index testing is a targeted approach to testing people who've got contacts with people living with HIV, so they're exposed. And this modality yields the greatest effectiveness of identifying people living with HIV. Have a look, 12% out of all the index testing. The next approach that's being implemented by the project, and that also helps us retaining patients in care, would be decentralization of services to the primary healthcare level. As of today, we have 32 primary medical and sanitary assistants that signed the agreements on the full range of HIV services. That's enrollment in care, that's prescribing ART, and the first results of implementation of such decentralization can be seen on the screen. And I would like to highlight some centers that, starting this year, January 1st, yielded great results on identifying people living with HIV, and they are mentioned on the screen as well. And I would like to share 2 success stories with you. This is an 18-year-old girl who resorted to family physician with acute respiratory infection, and the doctor didn't really like the course of this infection, and the physician saw that the girl had plenty of flus. She was offered HIV testing, she got positive result, and she was enrolled in care. They prescribed treatment, and this girl is being treated at the primary healthcare level. And luckily, we've managed to identify infection at the first clinical stage, and the person is successfully getting treated. The second success story would be a woman, 65. Family physician paid attention to the fungus on the nails, and they offered her HIV testing. Unfortunately, the result was positive. She was enrolled in care. The therapy was prescribed, and that was the second clinical stage of HIV infection. So the project is aimed actually to have more such success stories, for HIV infection to be identified at the early stages when there are no manifestations of opportunistic infections still.
What I would like to mention is that almost every primary care center is provided with a TV because of the project, for the importance of showing off within the project developed video materials. And one of such videos that are replacing pre-test information and provides for a doctor an ability to provide those services, I would also like to demonstrate to you. HIV is a human immunodeficiency virus. It weakens the immune system and makes the body susceptible to infections. At the beginning stages, the symptoms might be absent. This is why people don't even know that they have HIV. HIV is being transmitted through sex, injection from mother to child, and or AMTCT. So if you think you might be infected, make an HIV test. It's fast, free of charge, and confidential to be sure in your status and to know what you have. So those are videos that are demonstrated in our project facilities. Also, I'd like to mention that we are providing helping with integrated services. Apart from HIV testing, the project is also supplying and test for diagnostic B and C and syphilis as well. What you can see is the results of coverage with the services on the level of project facility. And I would also like to say that a bit of the change in approaches on the primary care level, on the establishment of the cabinet of integrated services, or we do have a primary care centers in Lviv that made a decision, and for community funds created the integrated services room that have been processed and equipped with our project, where not just HIV testing services are provided. Our hepatitis, syphilis can be TB screening, can be screening on other diseases as well. Our project conducts a lot of work on training of health workers. Since we saw the results of the survey that mentioned that one of the important components is training and education of health workers how to provide integrated care in accordance with the patient pathway for that. The project has 16 training rooms in the whole health facilities. All the trainings that the project is doing, and then within that, they're registered in the testing center, Ministry of Health, and for participants that are taking the list of points that have successfully finished the training, they're issued a certificate of national sample with the continuous professional education points. What you can see what number of training has been conducted, how many health workers have been trained. Apart from the training, we're also doing on-the-job training, and then when we are discharging the work team during the monitoring visits, and then I would like to say that among the training rooms, and then we have processed a training room in one of the health facilities in Kherson. Unfortunately, it's in the shelter. It's placed in the shelter. Regarding the challenges and plans, military aggression, damaged health facility, critical infrastructure suffering, disruptions with heat, electricity, water supply, presence of the internet connection, all of that puts a stress on timeliness and quality of services provided. But health workers, not just within the health facilities, are continuing to provide it. They're holding the line, especially the ones that are working in different ways. The deficit of workforce resources is a challenge, especially if those health facilities are near the front lines. The lack of state funding, and then they're also but we are also start to work. And I would like to say thank you to each health worker that's working today, especially the ones that are working near the front lines. The project, and then they're just the line of work that I did before. The project approaches standardized patient pathways and all the developed materials. They might be institutionalized or spread to other health facilities, and they're not supported by the public health centers, and then that are the recipient of the project. And then the three modalities as the different options of access to services, to HIV services in health facilities. It has a very big meaning to spread the access to those services. That allows us to increase the amount of HIV testing, increase the detection, and all of that can help Ukraine to achieve control over HIV epidemic. Thank you so much for your attention. Thank you so much to health workers, and glory to Ukraine, glory to Hero. Thank you so much, Tatiana. I'll ask you to stay. And I'll ask you to stay because we have one question. It starts with the question that Tatiana, the results are fascinating, but the question sounds as, what do you think is the most effective of your approaches? Is it training of health workers, working with the documents, or just spreading the information and awareness raising material? Thank you so much for the question. The question is very nice and needed. But to solve that something is there, the most effective, I wouldn't say. And we think we see the best activities where there is political will from the leadership. Training of the personnel was also a significant component because we are also seeing results. Even after the conducted in our lecture during monitoring visit, we are seeing completely different stages, and then during the monitoring visits in that facility, and we are seeing that the support for the funding, and we are seeing the targeted, and then for whoever is requiring those services, and we are seeing the results. I've demonstrated some of the results of some of the primary care centers, and I would just like to say that after conducted trainings and facilities, after in negotiation, discussions, roundtables, and the health facility leadership, health workers, and leadership, they've been so motivated to give those services that we saw the results. When 1,000 have tested in 8 months of this year, when we see the detection of 16 people delivering HIV on the same one primary care centers, not even in the year, when those people at the same time been concerned the diagnosis and they're at the same time and to treatment, and we are speaking about timeliness, continuity, and making services closer to the person, a human being. So the whole package and the place of residence of this person. And this is fascinating. It says all the component and compliance or political will of the leadership, training and all that gives a choice to the patient. If the person came in and even if the health worker proposed testing for HIV in the health facility, the person saying no, we are facing those issues. What we can propose is self-testing, and this is another chance for a human being, if there was positive status, and then to be diagnosed and timely prescribed your team. And then wish you luck, and then your very much complex line of work. And the next stage, which is the primary care, is one of the main entry point into the system, especially near the front lines. And I'll ask you to the floor, Alexander Vlasenko, the head of the primary care center number 1 in Kramatorsk City, and then Alexander, the floor is yours. Greetings, and I didn't prepare like a presentation, and I'll just try to tell you about our experience of our facilities in Kramatorsk City, and we've started to implement because of the past project and the integrated services starting up for the patient with TB in 2019. At that time, our center, so that you would have the understanding, it's served for 120,000 population, and it's part. There have been 10 ambulatories that has been placed throughout the city. This was rural areas, and then the people that have been in Kramatorsk, and then therefore by understanding that we have this issue, there are patients with TB, there are patients with HIV, and then we were also started in the registered space for those patients. And we took a TB doctor or pediatrician as a part of our team. We have at the Vita room, and we had a site of opioid substitution therapy. So all of the patients declared, and then in our city, they could have went through testing, and they could have went through then treatment, and then in future to referral to family doctors, and then within our facilities. Regarding war, we had a very strong lab, and even now, And then we are doing TB testing, and we do have gene experts in the level of the health facility. We do have fluorography equipment for patients. We do have testing, and especially since I mentioned before, we have the Vera room, and despite full-scale invasion in the Vera room or trust room right now on the ambulatory track, there's 512 patients that have, and I think this is the level of trust to us, to our personnel that's managing those patients, because 70% of them are not in Kramatorsk city, but they don't want to be discharged from us because we will line connection through the email, and then they're going through testing, and then they're going for testing and testing. Since so far we have this wonderful opportunity, we are bringing our test samples to Kharkiv, since the situation still permits it, and then logistically we are capable of doing that. And then we're sending medications for treatment. We are telling them you can change the sites and you can be transferred to another health facility, but so far so good. And they don't want to leave us. They don't want to be discharged from our services. And also now our health facility is being relocated, and because you know what is Kramatorsk right now, and this is the 7 kilometers from the front lines, and then independently from that, the Kramatorsk still has doctors in primary care and secondary care. They're provided for the document, but from this year we've opened an ambulatory in Perichin, Zakarpattia, and then slowly but surely, because I understand that the safety situation, unfortunately so, day by day, it's not getting better. And require that the patient are moving out from the city and medical personnel is moving out of the city, and we really want to, for the level of medical care that we were able to preserve so far, for it to stay, and then the medical employees, medical workers, and the equipment that we've acquired throughout the years. Therefore, right now we fully relocated our lab into the Perichin city, and from next Monday it will start functioning. And patients, we are also slowly but surely signing new declaration on the new place of services provision, the ones that want to in the future also work and stay with our health facility. This is why, what am I alluding to regarding this integrated care? Why did we start this? Because of the project, because of the equipment, because of the team and the understanding. I always said that I, as the leader, can be responsible for a function when we have equipment, when we have the opportunity to manage this. And so far, since we didn't have testing by a gene expert, this was connected with logistics, and then especially for far removed ambulatories, when you know that you can answer this, and then for that timeline when it has to come, get tested, and then as soon as possible the information would go to a family doctor, you would really understand that you can influence the pathway, and then to make it in a way so that your patient is not going anywhere, and then they're going to stay in a family doctor. And then before war, we had this system, and a doctor was an HIV, there has been a physiatrician or a TB doctor, he consulted a family doctor, and it was very much easy to use because he could have reached out. It was like a supervision per se. It wasn't a doctor from another health facility, but it was just as the doctors that worked in our health facilities, and they've managed those patients. And then the family doctors, they were more so easy to use, to reach out. They were more so felt comfortable and at ease, and we were able to control those processes. If you have any question, I'm more than happy to answer. Thank you so much. Well, thank you as well. We were hoping that we will be overextending, and we are running you before. Why men are showing such a trend in those days that they're presenting shorter than women? How would you explain? We're just respectful of your time. Okay, thank you. Do we have a question? Yes. Dear Alexander, 2 questions to you from the audience. What are the biggest issues you're facing because of work? Do you have sufficient access to the provision of medication and workforce? The main issue is the workforce, because this is something that we can't really, or something that we can't really influence, something that we can't really, in a way, plan or do something, because I don't know. Like, I have one level of personnel, and then the person might say, "Oh, I'm leaving and I'm not working here anymore." Therefore, for the future and then experience, it's perfect when we're saying that we have a function. So right now they're saying that there has to be one person in a health facility that has to be responsible for managing a patient with TB. And I think that every family doctor has to do that, because the system has to be sustainable. When just one person is responsible for that, it says goodbye tomorrow, then tomorrow this function is being left alone and nobody's answering for that. Therefore, for my training, I am a family doctor, and then for 15 years I worked as a family doctor. Therefore, I think that if you're saying that this has to be done by every family doctor, then I'm against for a function to like a person to be responding, because tomorrow this function we can lose because a person just went away. And then what you need to do is that if we want for this function, if you're speaking about the primary care, you just need to do this in a way so that this function would be responsible for the team. Team is a family doctor and a nurse. Regarding medication, there was a question. Well, thankfully, so far, because of the help and assistance of not just donors and the health department, Ministry of Health and Logistics, medications are present in the city. But because of the situation, when daily you have rocket hits and daily the transportation bridges and everything else being destroyed, and to get from Kramatorsk into Dnipro and Kharkiv, it's very, very hard. This is why it happened like that in 2022, when we had a collapse on the medication, when the pharmacies closed, not because they were officially closed, because the personnel just wanted to quit. And at the time, the pharmacy just had 1 or 2 pharmacies per city. And at the time, what we did in 2022, the pharmacy hub, when we got medication brought to us, even made quote-unquote pharmacy, because the option when the donors are coming and are issuing to the patient is taking everything, whether they need it or not, because they don't know what will come tomorrow, what is the humanitarian aid. And then there are people that require and they don't have the level of access. So far, we are okay, but this is an issue. Were there any issues to receive funding for services provided on HIV, TB, and OST? Are you receiving funds for one patient in a month if you were providing timely services? So will you receive funds for one patient per month if he was received all of the services before? And so this is as planned. For example, we have a package for HIV, and then receiving funds from this year from the OST package. We've said no to this, and let me say why. And on OST, one person was responsible for. When we had experience in 2022 that first she'd been there, then she moved out, and she'd get back. then there's going to be nobody to provide those services in the facility, but this is a specific service, and then the person is going for training, and then they have the skills, and then this service is not going to be provided. This is why we said no to the package. And on other packages that we have a problem on TB or anything else that's just it wasn't there. And then what kind of assistant can be of use for the work of health facility in such a complex environment? Well, I mean financial assistance for health workers and the motivation, and then all of the other things, even though I can't really compare any financial support and assistance and that are near the frontline personnel or the centers when we have shellings, because at first it getting hit, then there's an alert. So when it came in and the alert has started, it's just there. So you're been afraid of something happening. And what am I saying then? Where they're asking why you're not going to the shelter, and then there's no really point. You either have to live in the shelter or you're just getting used to the situation. And then I would just like for our personnel for additional motivation, for them to understand that they are risking not because they have to risk, but for something. It's even hard to hear. Is there a social support for patients in the conditions and environment that you're working with? Since we still have social services representative, we're trying to pass those patients to them. Since we have that ability right now, it's very much restricted, and so we have our own mobile palliative care unit, and so till that time we have 2 doctors and 3 medical nurses that are providing this care. And then one, unfortunately, but this is her choice, she started to serve in army. Another doctor thinking of moving out. This function we might lose in the nearest time, but till this time, when we had such a tight cooperation and with the social services and for others to manage such patients, and even social services, they have the same people as we are. They're also moving out. And this is a human factor that we can't, unfortunately, influence in any way, shape, or form. And this situation isn't safe because right now it wasn't there before, but in the last half of the year, even on cars, it's hard to move in Kramatorsk, and then it's very much unsafe because before we thought that the medical transportation, and that way the drones are not going to touch it. No, they're targeting us. So you were saying 20 times, and then we are saying no for servicing patient at home, even though we fully understand it before. It was our advantage because there's a lot of patients, unfortunately, in Kramatorsk that are staying, patients of advanced age, they're staying at home, and patients are, and then this is not just the further away areas, and then the elevator is not working, and so medical workers and everything else, and then the visiting the patient at home. But to target a doctor, and then he went out, and then what I would say is that we are having our vest and the helmet, and then the equipment that detects the drones, but this is the situation that allows you to at least somewhat protect your population and personnel. But unfortunately, with every time, it becomes more and more unsafe. My psyche in the oldest years, they're not doing well with the horrors, but you still understand that it's very much unsafe. But I do understand because everything sounds bad. What I can say, just please try to stay safe. Please try to take care of yourself in your very much hard line of work. And then I'm speaking to donors. They're reaching out. What do you need? What do you need? What do you need? And then what I wanted to say right now is that like the armored vehicles for medical personnel, because, well, and I fully understand that when there is a call, when the patient has an MI and say, oh, we can't get to you, doctors are dropping everything and going out. So there's at least some, not conditional protection when the drone hits. Beg your pardon, but foundations and donors can be reached out with such a request. We are reaching out. Unfortunately, it wasn't the priority. And then for military personnel, and when we got this means of transportation, we provided it and it did everything, but we just need to find like a priority or anything else, because the safety has to be with safety. And because I understand that that this unsafety is when we have an armored vehicles, it's still a bigger priority than we still understand that there is a protection, because the regular piece of medical transportation and armed vehicles and everything else, armed vests, that they're not protecting from drones. So this is why this is the conditional assistance and support. So who would be a response to right, the Kramatorsk required and armed vehicles, but we will be texting, speaking. Thank you so much for all your line of work, for your service, and for please stay safe. Please stay safe. Who could have thought? And then it's really hard to get used to this. This is easy. This is clear. And then we can only be fascinated by all of you. And then we are moving the TB and coordination of the specialized care with other services. And right now to the floor, I'm welcoming Lubomir Rak, Director General of Lung Health Centers, Pulmonary Health Centers, and we will speak about this topic. Lubomir, please do go ahead to the microphone. Dearest of friends, it's very hard and to present after Kramatorsk, and we knew this, but from to hear this from the source itself, and the enemy will die and will win. I don't know if I, as a man, can go really brief and quick and short, because the presentation is quite long, and I'll try to make it as brief as possible, but it has to be presented because of the information it's in. Thank you so much for this wonderful opportunity to present our experience of working with the integrated care for patients with TB, HIV, opioid substitution therapy that is in our mandate or in our set of responsibilities.
Now, a few words to set the general context and tell you about our institution. So we have a TB clinic or TB center, and several years ago we conducted a rebranding, so to say, and we are not just a TB clinic, not a tuberculosis dispensary, but a lung health center. And in Ivano-Frankivsk region, all over Ukraine, they know that we deal not just merely with TB, but we go wider. That would be a substitution therapy, pulmonary pathologies, HIV, and even beyond the pulmonary pathology, because we got turned into the multifaceted medical institution. And actually, yes, we specialize in TB, HIV, and everything around these conditions. So, we've launched or established two surgical departments, the reconstructive orthopedics department. So we have a surgical department with an emphasis on thoracic trauma, then orthopedic trauma department, I've mentioned this one, and we emphasize the extrapulmonary forms of TB, and the need in Ukraine in such a care is there, especially it pertains to bones TB and joints TB. And at our center, we have a palliative care department with an emphasis on patients who require this, so to say, this is socially disadapted patients, and we are trying to find a location for them to stay until we don't find a spot for them. They stay with us. And this April, we launched yet another department of emergency care, and we have a busway on urgent medical care, emergency care, and well, for sure, we specialize again because maybe this patient long ago had TB, and stigma, unfortunately, including in healthcare institutions, is still there. It was not yet dealt with. Well, this doesn't pertain to our center because we've been working with this for ages, and such patients are brought to us, and we provide them with the surgical interventions, therapeutic care is provided to them, neurological assistance is granted. Well, strokes, not yet. We don't have these packages, but this is to say yet. And this is the structure of our lung health or pulmonary health center. As of today, we have two TB departments, two surgical department, therapeutic department, surgical ward, blood bank, pathology department. What I would like to emphasize a bit more would be outpatient center that is comprised of three structural subdivisions. First one is the laboratory, then the polyclinic department for people with TB, and the third one for patients with HIV/AIDS. The latter ones, the latter two departments, pertain to the topic of today, and especially this pertains to the topic of the integrated care, because in this outpatient center, especially at the diagnostic department, we've got all the specialists who, well, we don't send our patients anywhere. We welcome them all, apart from those with strokes. Others are getting assistance at our clinic. That's a maximum integration of patients in our institution. We even have gynecologists, urologists, dermatologists, and all the necessary specialists to provide counseling to those needing it from any department. And we have an X-ray department, we have CT, MRI, so the patients who resort to us, especially this pertains the integrated care, are getting all the necessary assistance from us. Few words about the structure all around region. We have a unique opportunity because in each of the 7 districts we have in our oblast, we call them rayons, and we have 73 amalgamated territorial communities We have 210 centers of primary care, and we have 39 TB specialists, 29 of them at the inpatient level. So we have TB rooms. We have 11 TB rooms in 7 rayons of Oblast, and for sure they closely cooperate with the physicians of the primary care level, and it makes our lives easier in terms of dealing with the patients. Patients were asking what will happen on the 1st of September, apart from kids going to school. Well, we will start passing on the patients who are not having complicated condition to the primary healthcare level. And I believe this will work properly. So, the key areas of combating TB: early detection, high-quality diagnostics. We have it. Efficient treatment. Check the box. We have all the TB drugs. Prevention of TB, vaccination, immunization, treatment, prevention of latent TB infection. We have infectious control department, and we closely cooperate with regional CDC integrated services. We are going to talk about patient-oriented approach for sure. Epidemiological surveillance, monitoring, intersectoral cooperation. I will touch upon it a bit deeper. And R&D, implementation of our innovative technologies, including AI, thanks to our donor that helps us diagnosing TB at the inpatient setting. So, item number 1, early detection of TB. This one still requires significant improvements and significant efforts of our center, as well as further close cooperation with the primary healthcare level, because if we deal with the newly diagnosed TB cases, but 47% out of those this year would be destructive forms of TB. These are very complicated patients. This tells us about late detection, and that's the key emphasis for our improvement. Integration of services, interaction of HIV, TB services, primary health care. I was touching upon it already. We have a regional development plan on the basis of all the regulatory documents. We agreed all with PHC, specifically TB department. We cooperate in this regard, and everything works just fine. This is a patient's pathway. That's clear that the inpatient treatment is also taken into account here. So, more than 80% of newly diagnosed TB or recurrent TB would result in outpatient treatment, meaning inpatient treatment is granted to 20% of clients, and we have 100 beds for these patients, and usually not more than 50 patients. Usually these are socially disadapted patients, or those who require the inpatient care. Integrating care. On the 4th of September 2025, our center and Lviv Regional CDC signed a memorandum, and de jure we confirmed what we were always doing de facto. We have great cooperation, we exchange data, We exchange various statistical data. We coordinate our actions, and we conduct joint visits to the communities to check up patients. The regional CDC is providing its mobile laboratory where the patients are tested. We have 2 mobile X-ray rooms that go alongside, and we test all the patients. Well, they are not patients. They become patients after they get positive result, but all the residents of our communities. We have scheduled visits, regular visits, and we are actively using our 2 X-ray cars to deal with the patients. And we actively cooperate with the primary healthcare level for them to inform people that we are coming. Within the first half a year of 2026, we've conducted 84 visits. We checked up more than 3,000 people, and 10 out of them turned out to be TB positive with active TB. And this being the case, the digital X-ray installation provides us with an opportunity to identify other pathologies. So we've identified more than 300 other pulmonary pathologies and passed the information on to the family physicians for those to take care of the patients. Within our territory, we have got 13 gene expert devices. All our TB specialists know how to operate them, and within the 6 months of this year, performance or efficiency of the Gen Expert utilization is even higher than expected. And actually, out of those who were analyzed with Gen Expert, 13% had active TB case. Again, intersectoral cooperation, very good and very important decision was taken on having territorial communities free of TB. We have a coordination council, and there we consider all the issues pertaining to TB, HIV, AIDS, substitution maintenance therapy, viral hepatitis, etc. And we try to involve all the civil society organizations working with this topic, and the resolutions of our coordination council are mandatory for the whole territorial Lviv region. And so far, within 73 communities, we have signed 45 memoranda. This is already a very good result. It highlights that the leaders of these communities and communities proper know that within their territory there might be TB, and there might be patients with HIV, and they know about this. A lot of them understand it, and they have already launched certain TB and HIV programs within their territories. And this is also important from the viewpoint of social work in these communities, and they coordinate their activities with us. And we have a tripartite memorandum: community, regional CDC, and our pulmonary health center. So 3 partners are here. We've made a decision that till the end of the year, all 73 communities shall sign such memoranda to make their community a TB-free community. Psychosocial support, apart from the state-run program and the Global Fund grant, within which are TB Patients are being supported and they are granted with medical psychosocial support for 6 years for sure. We have our oblast level program, regional program, and there we cover the patients that were not covered by these two programs I've just mentioned, one state-run, one global fund, one, and again, we allocate from 4 to 5 million hryvnias to cover these areas: TB, HIV, and we support also shelter for IDPs who have got HIV status or their families, or those who have active TB or had TB before. This still tells us that stigma is there and some temporary stay places for HIV positive patients due to some reasons do not want to welcome these patients. So in our region, starting from 2022, we still support the shelter, and we welcome patients who don't have a place to stay and who do not where to resort with their TB issue. And now challenges. Well, I was already mentioning late identification of a disease. Significant attention is paid to a pediatric cohort. I would like to pay attention to that. Then strengthening our activities among the key populations. There is still space for work, especially pertains to the territories of our oblast around Sheptytsky city, where we have mines. And it's difficult to work with this category of people, but we still try to identify the latent forms of TB. And we try to identify all these latent forms of TB, and we try to identify the ex-Grinder's disease or the schistosis. We are doing our best, and I believe that till the end of the year we will achieve good results. So we try to have a comprehensive approach to combating TB, as you may see on the screen. We support the patients, we've mentioned that already. We try to decrease the time between identification and launch of the treatment. What's mentioned here on this slide, 60.4%. That's a critical challenge. These are patients who are diagnosed with both HIV and AIDS simultaneously, and actually TB is the key mortality factor among this category. The dynamics of contracting infection, actually 80% would be still the sexual routes. The age group is 25 plus, and we see an increase in testing by 18% thanks to Reach 95 project, and I'll tell you more about this in one of the diagrams. So, in 2026, so within the first half, we have tested more than 19,000 people using various testing modalities, and 1,087 were representatives of the key populations. If to compare to 450 in 2025, that's already an achievement. So the number of those from the key population covered got doubled. And in 2020, we've tested just 3,000, and we've tested more than 19,000 within the first half of this year. We are happy about this. And 20 newly born children from HIV positive mothers are free from HIV. That's a good job done, and I believe we really did good job with these pregnant women while working with key populations. HIV, AIDS diagnosis, which are diagnosed simultaneously, and unfortunately in 37% of the cases that's already the fourth clinical stage. This is something we need to work on and keep on working on. Awareness raising, informing people, and the quantitative indicators shall lead to qualitative results. HIV plus TB, 43.8% of patients have this co-infection. We're taking good care of them. We're keeping a watchful eye on them. But 14 people, meaning 63.6%, still died of TB after having HIV-TB co-infection. In general, 22 people died of AIDS. That is unfortunately really the infection that might result in lethal cases, and early diagnostics of TB among HIV-positive patients is a decisive factor for survival of these patients. The regional laboratory that we have just one, actually, ART sites. We've got 10 of them, and the key site is located in Lviv city. You see that actually 60% of the patients from all the oblasts are treated at our center, and usually these are difficult patients with co-infections, TB. So combating TB, medical system of Lviv Oblast control over the epidemics up to 2030. Civil society is helping a lot, and we cooperate a lot with the civil society. That's Anti-AIDS Foundation, 100% of Life. That's Avant, Global Alliance, and for sure Reach 95 project. It's really operational in our oblast, and for sure the project is gaining great successes in terms of combating TB. Various forms of testing are offered. We changed the approach, and we are offering active screening, namely the health workers initiated one. Our strategic priorities for the second half of 2026, the medical priorities, the managerial management priorities, and the social ones, working with the communities. So these are the institutions, namely 11 institutions that are offering substitution maintenance therapy. We offer it as well. And I would like to express my gratitude to the project of PAS. Thank you for assistance you are granting, supporting efforts to counter TB in Ukraine. So within the 6 years of activities of our training center, around 5,000 physicians and nurses got trained on TB management, on case management in cases of HIV/AIDS. And within the first half a year of 2026, we've conducted 23 trainings, and 450 specialists from all over Ukraine, not just our region, were covered with this training. Family doctors, nurses, and it happened in our pulmonary health center. Apart from this, procurement of equipment is actively taking place, and everything else is mentioned on the slide, what kind of great assistance we had and we still have from BAS. Also, I would like to express my gratitude to Public Health Center. We have great cooperation, and for sure with the TB control departments, HIV/AIDS control department. And we hope that by joint efforts we will combat TB. We will take a great care of control over the spread of HIV infection. And thank you for your attention. And thank you to the Armed Forces of Ukraine. I'm grateful to our defenders who give us an opportunity to be here, gather here, and discuss the important matters. Something we can solve by common efforts. Thank you so much. Thank you, Mr. Lubomir. I'm grateful to you. As you understand, there won't be any questions to you. You've mentioned it all, and we've taken a bit too much time, but still the information is important, dear friends. And if you have questions to Mr. Lubomir, you can ask those during our short coffee break. And this break is going to happen after the final presentation I'm going to announce now, and we will summarize the block of presentations with a look of patients organization. What helps persons staying within the pathways when the medical indications are not enough? We would like to invite Halina Zavyalova, consultant on social issues of charitable organization 100% of Life, Kyiv, Oblast Kyiv region. Miss Halina. And using this opportunity, I would like to remind you, you have to stick to timing. It's there in front of your eyes. Let me help you a little bit. Is this okay? Hello, everyone. Today, I would like to speak not just about separate services for people living with TB, HIV, substance use disorders, but rather about what's happening with the person when they are getting the services. In our project, there are plenty of structured services. We have social workers, we have patient school program, as well as case management in case of hepatitis, TB, medicines delivery, also the contact details of social workers to reach out to them, system of reminders. So actually this is not the question whether we have resources, whether we have infrastructure, we have it all. But the Thank you. But the question is, in what way to actually make these people be adherent to treatment? There are plenty of tools, but real life shows us one important thing. Sometimes a person is still being lost to care. And then the question is, there's a physician, there's a social worker, there's medicines, all the structure, all the infrastructure are there, the reminders are there. How come a patient fails to come and fails to continue treatment? Let us start the conversation with this very question. So quite often the problem is not with the absence of the service proper, but the problem is that behind a human behavior there is always a reason, and we need to look at the reason. If to have a look at our programs, we will see a clear-cut structure there. For example, working with people living with HIV. We offer them patients school, which offers certain sessions, which follow certain logics of activities. This is a very interesting and great tool because it allows to speak systemically about adherence, treatment, and living with HIV and self-management.
Working with viral hepatitis, we are also using structured sessions. In TB, a special meaning is the regular support, control of the treatment, assistance in preventing gaps in treatment, everything that's needed to preserve the patient at treatment stage. But I would propose for us to look at this from another side. The structure looks at the minimum that we have to provide for, but the life of a human being is not always within the structure of those 5 sessions. And also from what is happening in our life, and then the life is constantly changing. It's either COVID-19 pandemic, then we have a challenge in war, and then every day we have a changes in the needs and what is happening in the country itself and the life of every patient and what are we doing. And then the social worker is just continuing to do the consultation, not because it's not foreseen by the package, or they're just the special services or any kind of services, because we can't really tell to a person, and then this is outside of the services, and we'll finish, and we're not gonna continue later on. And therefore, there is an important question whether the quality of assistance is dependent, how precise is the to say something outside of the job and just to say something outside of the scope of his work to be a part of that system. And especially you can see that after the HIV positive status, then the person faces that, and then the most brightly this is presented when a person for the first time can be diagnosed, and then we can just give them the information on the treatment. We can make the initial consultation, secondary and tertiary, to make the whole school for the patients. But at this time, they're understanding what is right now. How can I live with this? And then how to tell a partner, and then whether I'll be left alone from the job or whether my life will be continued. And then number of structured session might not be present. They might not be able to cover all of the things that the person has in initial issues and moments and complexities that they've passed before. And then I think that it's important to put not just the mandatory packages and then the request of the patient and the client, and can be after the given consultation and a month after all of the package of the service in a year and 5 years, and the person has the need in additional knowledge, skills, consultations, because the time is going on and the person's needs are changing. So what kind of issue we're facing up front? One of the typical mistakes, sometimes it's too fast that we're calling the behavior of the human being as the low adherence or low compliance. The person didn't come in, meaning they're not motivated and they're not motivated enough. Maybe in this stage there are complexities, something that obstructs her to be motivated. Not getting medication, they're not interested or anything. As the previous speakers had mentioned before, we are living in the completely different reality, the reality of war, which are showing us something that we can face or the patient can face themselves. They're not answering the phone, meaning they don't want to get through treatment. And if we are to put a pause and then we're trying to understand and then we see another picture in this situation, and then maybe the person is afraid, maybe the person did not perceive their diagnosis well, maybe there are complexities with the medication taking in, or maybe at this time the behavior change or other factors. And then therefore you constantly need the support and to highlight that there is a need for other specialties. I think that separate role of the psychologist. This is not a psychologist has to be involved in every package, every program. And then on this stage, I would just like to separately discuss in the psychologist. We are frequently perceiving a psychologist as that have been involved in case there's any mental health disorders, but people that live with HIV, viral hepatitis, TB, this issue is very much wide in the services of psychologists. The psychologist can help you to understand the reasons why they skip medication taking, and not just that they are taking that in, but get in depth of that issue. Maybe the person on that stage, they faced with stigma, with discrimination, and then that the person is ashamed that person have been infected by a virus or another conditions and disease. They're most likely the psychologist himself who just can cover this issue that other specialists cannot really deal with. This doesn't mean that the psychologist can replace a doctor or a social worker. They can add, and then to get in depth of, and then to receive is much more support so that we can continue the treatment itself. The doctor can prescribe treatment, help with the changes in the treatment, but sometimes and not always they can provide a mental health support or find the reason why the client is skipping or missing out on the treatment, is not compliant with the treatment or adherent to the treatment. Maybe they're facing a level of stigma that we might not be able to perceive, or so the medication can be delivered to the person but cannot be delivered the motivation to actually use it. Let's imagine the situation. The human has a medication, medical care, social workers always online, the doctors always online with them. Have to receive the medication you can, but the patient itself, the client, is skipping treatment. We are calling, we are reminding the ability to get treatment. Person is agreeing, and then in a bit of time, the same thing repeated, the same situation. In that moment, in my opinion, it's not enough to say that you need to take treatment. You just need to deal with the reason. What is the reason that the client's not reaching the health facility? The client's not picking up their phone or transferring the visits. I'll come tomorrow, day after tomorrow, or after a month. Then the person on this stage is just exhausted with the treatment. They need support. They need to be referred to in the correct way, and they need additional consultation, or just to conduct a supervision or consultation with a psychologist. I would even say it that way, what we're seeing gaps or skips, or this is not just a signal to a social worker to call again, but a signal for a comprehensive teamwork So what we mentioned before, that on every client, there have to be a special approach, integrated approach. If we want to see in the future to fight the pandemic and receive the controlled cases. HIV and TB and viral hepatitis, those are different conditions and diseases, and they have different lines of treatment, different patient pathway, but we are speaking about the compliance. And we're seeing many different things. The person in HIV might feel okay for a long time and saying, I don't need treatment, I feel okay. This is not like a person that came in, maybe that's not the best example. They fall down, broke a hand, it's painful, and then you just need to run to the doctor. HIV most likely going without symptoms, and then the patient themselves are saying, nothing hurts, nothing's of concern, no reason to see why I need to start the treatment, and then why I have to take the medication for life. And this is why in this case you need to have a team that can work with the different levels of barriers, stigma, self-stigma of the patient. So the practical model is we are having an approach in every case, highly individualized. We need to have as much information for the client, the mental health assistant, and then the complexity apart from medical care. There has to be a legal level of assistance. This is one of the areas that, in my opinion, they have to be not just one of the lines in the services. This is legal support. Most likely people with HIV, viral hepatitis, they have been formed a stigma that they don't know where to reach, that they don't need help and assistance, they are not okay with the diagnosis, they don't know. Some of them need to provide help, medical care, where when they have the right to receive free of charge medical care, and then why there has to be support. They are, for example, afraid of disclosing their status. They don't know who they have to inform, who they have to not inform, and then this part of, I mean, it's probably loudly saying that in the 80s, when HIV was the very complex conditions and disease, the stigma in many cases still staying, and then I guess this more so concern and more advanced age, or the comprehensive support is to preserve a human being for treatment. And here it's important, not just the social worker has to explain this, they has to have a comprehensive approach, and then the social worker has the role is not to see that the issue has legal character, but to just orient the person. This is the integrated approach. Sometimes a person doesn't need one service, and here we're just coming into the main example. People are not frequently going with an issue. They can be put into one category. They can have one issue and medical problem and a social worker plus and then either the medication, and then there's no readiness for the treatment, and then social worker is helping to the practical barriers. The psychologist is working with the internal barriers, with the fear, stigma, not perceiving the diagnosis. The lawyer is helping to protect the rights. If there's any complexity that can hold their ground legally for their own interest, to have good health in the future. if we are to take the integrated barriers and not living the fear, and then the person can, if you take out the fear and the rights are still violated, the issue is still staying. And what does mean the donor program? And in the programs, I would like to change the logic for planning to leave the structured models. This is a great approach. They're very much needed. And to foresee the consultation based upon requests, and then to in additional sessions when in this structure does not foresee that, they haven't created patient pathway. The third thing is that we need to include a psychologist not as an option, but that has to find in each program itself. Then fourth thing is to foresee for the legal concept, for legal consultation to all the clients that need it, and not to assess how many sessions have you followed the structure of the session, and then or if you have the, and when the main principle is that what we have to ask, if after everything we've done, are you going to stay in the treatment? Have you been able to fight those barriers of every specific person, and not because this was foreseen by the sessions? For it not to be hard to have additional session by the requirements of the patient, if you have one client can ask for a specific line of support in a specific realities, however they're changing daily. If we are to summarize, this is it. I didn't want to say that our models are not working. They're working well. For a long time, I am working with the people that are HIV infected, and I'm seeing that what was been there for 5 years ago, I'm seeing what is happening now. I'm seeing that how people were helped like 10 years ago. So step by step, we are helping, we are fighting with this pandemic, with those new challenges. And then I also want for all the models of this integrated care to be living ones, to be calculated under each client, and so in a way to hold them inside of the treatment. And then the person might need or bigger request than what we provide in the program, or they might need a psychologist today. Another client to need a lawyer, another client would need additional consultation. This does not mean that 5 years ago we worked with this client, that in 5 years he's not going to have questions, and so they're not going to come to you again. The person that has the change in life, overview, conditions and everything else, and then this is why you have to be ready and integrated, and that you're ready to provide care independently from the situation that will be faced by us. And we always need to understand that that the health and life, those are the biggest value of what we want to achieve. Thank you so much. Holiness, thank you so much. Thank you so much for your presentation. And also no questions asked. The time is up. Thank you. As I mentioned before, you can ask questions to your speakers during this short break. Let's see each other in 15 minutes. We'll get here fully here so that we can catch up with the timing, and then Right now it's time to rest, like hygiene and others, and then coffee, and then 15 minutes from now, we'll ask you to get here in this room again. Thank you so much. Dear colleagues, thank you so much for getting back into the room. I see that not everybody done so, hopefully because they had such a wonderful coffee and it's so nice to speak, but you will have additional time for that. Even during lunch and after lunch, and then we do have speakers, and then we're asking you to get back. In a previous session, we saw how integrated care is working on the special pathways, health facilities, needs of the patients, and then the route will be working without people who are providing for it right now. And so we will be speaking of the workforce, the please get back, what are the competencies, how to use the present potential in a transition period, how to develop nursing, psychosocial support, and then the work with the multidisciplinary teams. Let me remind you that by the QR code you can ask questions to the presenters, and then later on, if we have be able to articulate those questions. If you're not going to have those questions, this is not going to happen. This is why, yet again, I'm asking speakers to follow the timing. You can see it on the screen, and then we would really like for you to be able to discussions with the audience to understand that what are the principal questions that there are on your topic, and then therefore, dearest of friends, let's organize, and then let's move to the following presenters. This session is built on the principle of individual presentation, and we will start from the general vision of workforce policy and competencies needed for the implementation of changes. To the floor, we're asking Maria Banco, Deputy Head of the Department of Coordination of Medical Cadre, our workforce, the Science and Education and Ministry of Health of Ukraine. Welcome, Maria. Thank you so much for being here. Thank you so much, and greetings, dear colleagues. And then let's just start the professional activity within the health. Now, let me pull up my presentation. I don't know how it's done, and then if somebody can help me, thank you so much. The main law that regulates professional activities in the health, which is the grounds of Ukrainian government regulation about health care, the Article 10, and then the point 74 and 75, the activity of professional activity in health. Requirements for profession are set by the professional standards or by the absence of such standard by qualification requirements. And Article 75 is telling us that we became a health worker in the system, then we are required to pass through continuous professional education, develop, deploy, and to learn throughout all of our professional lives. Regarding the professional standards, right now, not for all profession in the health system, the professional standards are stated. This process is still ongoing. And then on fulfillment the law on the labor code, and with the National Agency of Qualification, we have created the Registry of Classification, job post classifier. And then you can look for professional standards that have been approved so far. And then if there's no professional standard, then there is going to be the information from the qualification requirements, and then therefore the qualification characteristics. And then right now, why do you need a professional standard for? What they're doing is that it has a list of competencies that a person throughout the education process has to acquire to fulfill any given objective or responsibility.
And as soon as we gain a profession, we start looking for a job. And for that purpose, the Ministry of Health, MOH, created a single web portal of vacancies at the HCIs. According to the legislation, each and every communal facility, healthcare facility, is obliged to announce the vacancies they've got at the unified web portal of vacancies. Also, you can see the search, you can select the region, the profession, you can allocate your CV. So it's all done to actually help people finding jobs. After this, we start the training. So we start our continuous professional development. And the majority of professional continuous development events are located at the website of the PHC or Public Health Center. You click the button, Continuous Professional Development, or CPD, and you can find a CPD matching your profession or based on the services provider, etc. And this is the biggest CPD hub, where there are plenty of various CPD events also. There is a hyperlink from this website to other hubs, smaller ones, but no less in the significance, the Academy of the National Health Service of Ukraine, as well as website of PHC, where they also place the CPD events. Moreover, there's the Center of Education Quality, and there you can find all the certificates granted to healthcare workers. And nevertheless, there are a few other matters we got used to, but... Oh, I broke something. No presentation available. But they are not present at the website of education quality. So this would be cycles of professional excellence and cycles of specialization. These cycles are made public at the educational institutions' websites that conduct such cycles. And something new for our country, that's peer groups. It was regulatorily approved in 2025. Usually such events are made public at the HCI websites that conduct this very event. So we conducted a survey at the level of oblast regional administrations, and as of May 2026, you see we have 174 peer groups, number of physicians who participated in peer groups, 1,138. You know, it was just recently introduced, and maybe not everyone is aware of this. So, in general, this is what pertains to professional development. Thank you so much. Wow, that was quick. Do we have any questions? Oh, no, we don't. Maybe anybody from the room would like to ask questions. Maybe while you ask yours, somebody will ask one online. Well, let's consider it a very dynamic beginning. Yeah, either they understood everything or nothing. Now I believe everything's clear. You know, those who are staying, they say it's very interesting, useful. So that was our key goal, actually, for today. Thank you, Maria, so much. I would like to remind you, friends, that we can be using the QR code to ask questions, and we can do it all, but so far to kill all the Russians. Well, okay, but we are working on that. We shift the focus of attention to mental health. Miss Natalia, we are usually experts on mental health, but how come we wish Ruskies to get lost of this earth? Is it good for our mental health? You know, it's rude. It sounds rude from the viewpoint of humanity, but, you know, somehow when I say it, I want all the Ruskies dead. My mental health flourishes. God forgive me. But it feels good. So, dear friends, speaking about mental health and psychosocial support skills needed by workers of different levels of care. And I invite Mr. Stanislav Chumak, head of the Center for Mental Health of Veterans and their Families of the Institute of Psychiatry of the Taras Shevchenko National University of Kyiv. Greetings. Greetings, dear colleagues. Well, my presentation is there. Great. So, dear colleagues, today we speak a lot about integrated care, about necessity to combine medical, psychological, social services around the needs of one person. But I would like to draw your attention to yet another component without which such integration would not be possible and would not be full-fledged. That's integration of competences of those specialists who are providing this care. We cannot build a truly integrated system if education, professional training, clinical competences, and even the mechanisms of funding will be existing in silo, separately from one another. So my key statement is very simple. Integrated assistance starts with how and what we teach to people who provide this care. So, in real clinical practice, a person usually doesn't come with the problem that fits into one specialty area. Patients with TB, HIV, or viral hepatitis might be depressed, might have anxiety disorder, PTSD, substance use disorders, or the use of PSAs, psychoactive substances, PAS. Also, psychological problems, stigma, financial problems, consequences of the war, and comprehensively, it all influences the fact whether the person will address to get help, the system to get help, whether they will trust the system, whether they will adhere to treatment, and whether we won't lose this patient from along the pathway. So comorbidities would not be an exception, but a daily clinical routine. And the question shall not be whose patient is this, but how to build a unified pathway for this patient. And namely, the systemic approach was the one selected by Lancet Psychiatry Commission. That's an expert group comprised of more than 40 international specialists, and the Institute of Psychiatry was involved to this group. In the first publication of this commission in 2024, mental health was considered in a broader sense than just organization of psychiatric services. This would be clinical assistance, education, science, legislation, human rights, and funding. In the second publication, Managing in War, Planning for Peace, they already analyze in what way this transformation is happening under the conditions of full-scale invasion and what must be preserved for post-war development. For today's discussion, one thing is really important. We can't reform a separate service in silo compared to the whole system. If we want integrated care, we need to have integrated clinical models, training of human capital, and sustainable mechanisms of supporting them. And here we face a paradox. From the up-to-date healthcare, we expect multidisciplinary approaches. We want psychiatrists, family physicians, psychologists, medical nurse, social worker, and other specialists to work as one team. But we train them separately. Every profession has got their own educational trajectory, own program standards, and professional language. And they are never taught the skills to cooperate, to work as a team. They start gaining that knowledge while working already. So the system requires the unified clinical pathway, managing comorbidities, but education continues. Still working in silo. And additionally, this fragmentation is reinforced by versatile or different sources of funding. So we need to do something with this, gradually at least. So a practical example of what we shall be moving towards, it's DAISY Ukraine. Our institute is participating in it. Mobile multidisciplinary teams of mental health demonstrate just another logics of assistance. In the center, we see not a psychiatrist, not a social worker, not a psychologist. We see a person and their needs, but around them we already see all the specialists. And it's also important to mention other members of the team here, because there's a separate area of DAISY. Looking at the integration of a specialist, integration of a specialist based on the peer-to-peer approach. It's not enough just to add yet another specialist to the team. We need to identify their role, the measures of their mandate, interaction with other members of the team, and joint responsibility for developing the patient's pathway. So a team would not result in just adding various specialists, bringing them together. Yet another important resource would be international educational networks. Institute of Psychiatry is managing ISAP Ukraine network, which has got access to evidence-based approaches in case of clients using psychoactive substances. Also, we are part of ICU-DDR, the network to decrease demand for drugs, and ITTC Ukraine, that's the center, the task of which is to help bringing best evidence-based into the real practice. So value of these partnerships would not be to conduct yet another training. The key function here would be a rapid transfer of evidence-based practices into education of human capital, and then bringing it all to the real system of care. One of the practical formats we've been using at the university would be peer-to-peer approach in the course of training consultants. What's important to me, not just the contents of the program, but how we arrange the training or education. In one room, there might be people with versatile basic training, medical, psychological, social, legal. People can be specialists in arts, etc. That's not a limitation. But they are commonly working on the competences needed for the teamwork. They learn how to communicate, set professional boundaries, identifying risks, supporting and referral mechanisms. A person shall understand not just what they can do on their own, but also where their competences and when they need to resort or involve another specialist. As I see this, these formats of education shall be scaled up. So the principle shall be quite easy: to bring together those and train them who will be working together later on. And what do we see in practice based on this? I would like to single out 4 key changes resulting from this. First, we train on comorbidities, not separately have courses on depression, separately on substance use disorders, HIV, TB, but to provide the trainees with the clinical cases where they've got all these challenges simultaneously, all the comorbidities as it's happening in real life. Second of all, strengthen the addiction component of the substance use disorder. Let's talk about this more deeply. And this pertains actually the postgraduate education, in-service education, and we need to have separate contents for those still in training and those who are in the CPD. Thirdly, we need to systemically introduce peer-to-peer training. Doctors, medical nurses, psychologists, social workers, counselors, peer counselors shall walk their training pathways together. And fourthly, train not just how to set diagnosis, but how to develop a pathway of a client, identify problems, support, assess risks, motivate to get treatment, properly refer, and what's the most important, not to lose a person between all these services. This being the case, we don't say that every healthcare worker shall become a psychiatrist, psychologist, or substance use disorder specialist. We speak about minimal set of common competences that are needed to work in this integrated system. And to wrap up, I would like to come back to my key statement. Patient is already integrated. Their mental health, physical condition, the fact of using psychoactive substances, traumatic experiences, social conditions do not exist separately just because our system put them into different baskets in different healthcare institutions. So we need to integrate not just the services, we need to develop common competences, the same language of identifying risks. We need joint trainings, and we need to develop teamwork competences, and we need to have share liability and to introduce professional stimuli that will inspire to work together. If to name one change that can help with ensuring continuity of care, I would call peer approach to training with a focus on comorbidities and developing pathways the key. So, actually, we need to speak about shared responsibility. This is not just a motto, but a real pathway for our client. Thank you, Stanislav. We don't see any questions on our platform, so I'm letting you go. And this is the round of applause to you. Thank you, Mr. Stanislav. Dear friends, and we move to CPD, continuous professional development and continuous education, and that should consolidate new competencies in the system. I invite Natalia Hritsova, Associate Professor of Department of Physiology and Pulmonology of Shupik National Institute of Healthcare of Ukraine. Natalia. Dear colleagues, greetings. Thank you, dear organizers, in the first place, to allow me joining this honorable group of people in this great event. Healthcare is changing rapidly, and today I would like to try to talk about something that institutionalization of CPD is not just a formality and not just a system of getting more and more scores. Listen to this word, institutionalization. It's like palyanica for us to understand whether that's our person or not. Okay, that was just a little joke. So, institutionalization of CPD is really not just a system of collecting points. That's changing the model of a professional life of a physician and responsibility, liability for supporting all these competences. So, we need to give an answer to two important questions today, and we need to be frank with ourselves. Why traditional formats of training are not enough, and whether such training always changes our clinical practice. Technologies are changing, standards, guidelines, protocols, regulatory bases. The functions of primary healthcare are expanding, and patient is becoming more and more complicated with more comorbidities. And we spoke about it for this today, so I'm not going to go into details. You can see all the skills we need to have on the slide in order to be a competent family physician. A family physician shall properly understand the issues of TB, comorbidity, HIV, TB, viral hepatitis, infectious control, mental health. We've just heard about this. And what's the most important here out of all these competences would be to develop a correct pathway for our patient. So this is not just the issue of how long we are going to train, but the issue is why, how, and for what professional actions we train our physicians. Meaning, who shall be involved into this training? Continuous education, well, for sure, that's the task of the whole team, and I'm grateful to the previous speaker that he emphasized that. The whole team that's involved to developing the pathway of a patient. If somebody out of the team, the list of whom you see here, from the nurse to the manager of the ITI, loses or doesn't use their competences, the pathway is going to be distorted and the patient would not be able to get professional assistance. Nevertheless, a special emphasis is made on family physician, not because they have to become simultaneously, as yesterday esteemed Mr. Volodymyr Kurpita mentioned, and today experts were saying, no, they don't have to become a TB specialist, infectious disease specialist, psychiatrist, social worker. No, they don't have to become it all. Usually, a family physician would be a person who is the first one to meet a client. So the key task of a family physician would be to identify risks, to know the next steps, and not to allow the person to get lost among all the services offered and the pathways and services, as it was mentioned today. Primary healthcare shall not know everything, but they shall know what to identify, what to do, and where to refer a patient further. And we will continue with the education. I would like to show you just one example as an element of a training experience of our department within the 5 years. This is not by chance that I'm showing these figures. They are not big, huge. Every year, as a department of a leading institution of postgraduate training, we are now called differently. It's a healthcare university already of the national level. But our department, TB department, it's called the Respiratory Medicine, Physiatrics and Pulmonology Department. On average, it conducts 32 two-week cycles of thematic excellence. And this would be 330 physicians whose training would be paid for by the state. How about the rest? Well, they have to gain their knowledge, paying out of the pocket, relying on sponsors, or they don't get covered with this training. Sometimes they need to be looking for alternative methods of gaining knowledge. But pay attention to other figures. Within 5 years, more than 9,000 physicians and 2,000 interns of almost all the medical specialties that are out there in Ukraine were covered by short-term training and gained appropriate competences on TB area. Have a look what kind of demand we have. There is not a single educational medical program, from proctologist to anesthetist, that would include looking a little bit at TB issues and issues related to physiatric issues, all the comorbidity issues, side effects, mental health. It all shall be included. And these figures you see on the screen bring me to the key question. Does always the quantity results in the developed competency. It's not enough to know. One needs to know how to act. So that's not a problem that we do not train enough, or we don't have financial opportunities to meet the demand, or maybe we don't lecture properly. The problem lies in the other thing, whether the knowledge provided turns into a professional action. Let me exemplify from my practice, and I'm grateful to Mr. Lubomir, who touched upon in his report, who touched upon this issue, because this is a very important issue today, a clinical one. A patient who suffers from pain in the back resorts to various specialists. They get examinations, get treatment as the patient with the problem of the lower back, but time passes and there's a key question. Can it be the spine TB? And only then the diagnostic pathway changes, but the time is lost. We see a destroyed spine. And this is not a problem that the doctor doesn't know about spondylitis and TB spondylitis. Experts know about this, that there is this therapeutic area. But the problem is whether a physician is ready in specific moment in time include TB into differential diagnostics and change the algorithm of their professional actions. This logic is universal. It doesn't pertain to TB only. It's universal for viral hepatitis, comorbidities, substance use disorders. The pathway written on a paper, and they are well written on the paper in Ukraine. They look ideal and they seem to be clear, but the pathway put down on paper doesn't mean that this pathway works. There shall be competences in the first place. And a competence is an ability in the necessary moment to identify the problem, to make a decision and act. Why one educational format is not enough nowadays? Because not a single separate format, even a high-quality one, can ensure competencies of a physician throughout the professional life. For example, the thematic excellence cycles mentioned today, yes, they are there, and they are great, but, well, the demand is great as well. But the thing is, the state order for these cycles is very limited, and this training educational format is a requirement to get funding from the National Health Service. So the thematic excellence cycles gives something a short webinar won't give you. The systemic nature of knowledge, diving deeper into the problem for a week or two, because the cycles last a week or two. And the practical component, then subsequent development of competencies, an opportunity to practically improve your skills, communicating with lecturers of the university department, which is also important. And this communication can actually ensure further assistance to these physicians, because later on they might come to the specialists who were training them with some complicated cases. Quite often physicians later on actually ask for consultations, show their clinical cases, and this is also the training, but beyond the training cycle. This is a training for both a lecturer and a physician. But the cycle shall not be isolated. Between such fundamental educational events, there shall be some short modules like clinical cases, and they are approved at the level of the state by all our regulatory documents, mentoring, guidelines, supervision, online training, peer-to-peer approach that was mentioned today. These are all very important components that shall be there in the educational life of a physician between these academic cycles, let's call them academic cycles of thematic excellence. So, it shall not be the competition of formats, but continuous educational trajectory. So, in what way we need to train physicians? We don't have to get concentrated on the topic. No, we need to urge physicians to take professional actions, meaning this professional action skill shall be the key outcome. This will change the philosophy of education and training. So, next to a lecture on the slide, you can see lecture is the old format of training now, but next to the lecture you can see the clinical cases consideration, algorithm of actions, simulation or tabletop exercise, team training, mentoring, supervision, and an opportunity to go back to an overcomplicated case.
What are we trying to do at our many and various training platforms? We have different kinds of training, and then right now, how is this being controlled with the level of knowledge? By tests? Is the test by control that they know something? Certificate is saying that they've been training, but the certificate received, doesn't equal to the competency really. The point of education for doctor to work correctly in the clinical case. And then therefore, there is a principal question. Who is supposed to make it so that this is not just a set of good initiatives? You can't put it's just in a doctor that are selecting at their own accords any kind of given and you can't really put to the provider of the educational services. This is the joint responsibility, especially for postgrad education, and then public health center, health facilities, and then practice in the region. You see this list with the function of every component. And then on the slide you can read out, because there's not enough time, and then I'll be reading it. I'm not going to be reading it out. And then on the specialized department, maybe somewhere you wouldn't like to hear it. And then the specialized departments in the university, this is academic training as a bridge between the evidence-based medicine academic and the real clinical practice. The other parts for the assistants, and then all others support that can provide and widen the circle of competencies by the education seeker. And then the practice has to form the request of the practice, has to form the educational request.
Не кафедра, не платформа.
Not a department in the university, but just the practice itself, and then the education to get to them a competent worker. In Ukraine, for that, there's also legal presented, and if you're speaking about this institutionalization, then the plan, our country, and for many times I have went through this institutionalization, and then there is a law on that decided upon the CPD on the national level. We have the decade of cabinet ministers that had formed the system-wide. We have the Ministry of House's order, practical tool for the implementation, attestation, and the points of here. So we have legal backgrounds or something, so that we can have a quality training, and then we would receive this training altogether. This is a very important step from the government, but I would just like to stress something else, the legal base. And then it creates only the framework, and institutionalization is happening when? And then when it provides the real continuous professional education of competencies. What does the centralization for me provide? The training of a doctor throughout his life is no longer his personal, and becomes a part of the system. And then we can also say that the institutionalization has actually happened. But I wouldn't like for us to put this system into the model that exists as of today. With our webinar, I've listened to a webinar, I've got the points I forgot, so we need to a bit of a different cycle. The need for practice, the need for training programs, and those needs was the list of competencies and was the list of something else. And acquiring those competencies, the use of them in practice, the risks assessment, results, and the new novel educational programs and new educational need. And then the projection of the doctor, and then the development of that altogether. How to understand that the training has worked. 50 points and that's it, a certificate and that's it. Successfully fulfilled task. This just confirms the fact that you've been there, but doesn't really says that there's a change in practice. And then the real pathway is the slide to you. The competencies, and then professional activity, the change in practice for a more effective one, and assessment of results for the patient. And then it's not the training that what doctor knows after the training, but something that he does differently in his practice. And then we don't just ask and then what had changed after the training. This is why I'll make 3 main transitions, and that will be deciding of the future of post-grad education, and from this separate event to wider system, and from the certificate to competency, from the competency to the result for the patient. And if you're really trying to institutionalize continuous professional education in that way, the education will no longer be a self-goal. And so it's only good when there are change in practice and then the change in society. There's joint objective, which is the competent table, and then a strong health system and a stronger patient. Thank you so much for your attention. Dear doctors, colleagues, I'll just leave you with one idea. We are investing in people today, and if you invest in people today, we will receive a stronger health system tomorrow, and the patient is the center, the team is around, and then the results are all together. Thank you so much. I mean, the perfect formula, Natalia. Have you finished? Yes. To us as patient, it really is nice to hear. And then, are there any questions? There are questions, and it sounds as the following way. Can you tell us, Natalia, is the specialization program up to date for the preparation of doctor, taking into account that they need the new competencies based on the system needs or not? Yes, this form of training as a specialization, it's there, but what is this specialization as the form of training? This is the achievement of a new profession. So he was a family doctor, he wants to be a pulmonologist, he was a physiatrician, he wants to become a pulmonologist or a family doctor. Therefore, this is a widening of getting another medical profession. This gives us an ability for the doctor to be more competent, and then widening this stage for employment and for equality, provision of care. And then regarding comorbidity, specialization exists. And then the only thing where there is a change in the format, then we don't have this form of training and the internship as the physiatry. So we mentioned before that we are, and at the end of the day, the doctor, he's getting the certificate of physiatrist and pulmonologist, and then the pulmonologist is acquiring the specialty, and then the specialty is the physiatry. They're not only acquired, especially for the recent graduates, they can't acquire physiatry really. and they need to have the specialization in family medicine. And then if there is a need to widen the professional skills and knowledge, and then they're receiving specialization in pulmonology. And then it's connected and widely discussed in terms of in our department, and when we are doing the specialization for pulmonologists, in one of the months it's almost dedicated to the matter of physiatry fully. So a month is spent of physiatry. So thank you so much. This is it. I was really grateful for your time that you've dedicated to our forum. And the next topic, which is the strategic role of nursing, and then the widening the capacity. So to the floor, Alexander Prokopchuk, a coordinator on the development of nursing on the Ukrainian Swiss project, Act for Health, a family doctor, whom I'm still living the stage to you. So thank you so much. I have just an idea of walking on this stage, and thank you so much. My role today is to highlight to you the potential of nursing and the implementation of this integrated, where this potential that has to be used. And I propose for us to do that through the history. I don't have a lot of time. I have a timer. We have more than 14 minutes, but then let's went through the development of health systems, and then understand how and where we reach to the point where the medical care has to be built around the patient, and why it has to be integrated, and what is the nursing, somewhere this is being used, and sometimes we can actually use it. So by getting deeper into the history, when the health system did not exist, the house was and then if you don't have the funds, then it just keeps growing. And then because the urbanization had happened, people started to live groups of people, and then they were dying in the group. So we couldn't really ignore that. Then there was military conflict, and then first of all you need the housing, an army, which is the connection of that, the economic question. So that then the progressive development of industrialization, and then it's losses for the government, medical science, bacteriology, and also we started to understand that we can somehow influence on that. And then not the last instrument, which is policy. So the government is the demographic, and then up until they started to take into account, and then they just asked for. And then less than a month ago, and I mentioned about the history of nursing, and I mentioned that the history of nursing is connected with Ukraine, because de facto it started on the territory of the country, of the modern Ukraine. It started in Crimea. So today I would just like to tell you about the first Ministry of Public Health, so the first Ministry of Health, and the first minister in the world was a Ukrainian, apart from Chernobyl, Ivan Horbachevsky. Right now his name is the medical university in Chernobyl. So the first one were inpatient. So the first health system was an inpatient hospital. Apart from the fact that it given us the improvements in education and treatment, reduced mortality, it was developing, and then all the medical workers, and they exchanged the experience, increased their that was effective. But then there was one thing of specialist care. What do you think it was? Specialist care is the most expensive known to us type of medical assistance and care. And humanity started to calculate funds and to look for other options. And they've understood that if before a disease, the sooner the disease is diagnosed, then treatment is much more successful and it's much cheaper. And therefore, the screening program started. So the prophylaxis started to be more actively implemented into the health system. But something that will make you closer to the patient has to be. And then in parallel, actively develop the primary care as well as the ones closer to the patient, universal, continuous type of medical care. In 1978, the WHO has declared that the primary care is the fundamental part of health, and if you're speaking about the official health system, then it's still a fundament. But there was another problem. Primary care is a type of, and I would call this a cabinet care. And then when the person is going out, the whole magic of family medicine is moving out. So people understood this as well, and therefore the community care started. And then if before that, and then they started the question, and the humanity understood, and you don't have to wait for the diagnosis. You need to find a person with the risk to influence that risk and to make it so that the disease is not there. This is how the profession of the community nurse, and then they actively implemented the other types of visits in the local program for health. And so far, slowly but surely, the medical care, and then they're also entering the stage of 21st century. And no matter how paradoxically it sounds, and then they're ready to fight for achievements that they've got into the 20th century. And then we've started to live a bit better and started to live for a bit longer. And then according to the WHO prognosis in 2019, one person was older in months 11 of 65, but in 2050 this would be 1 person out of 6 will be older than 65. So people that are working now, paying taxes, inputs, are getting any kind of input to the health system and going to go down, but people that are requiring that, then the timeline that's on the left demonstrates greatly how continuously the expenditures for health are growing in numbers. So those two sharp picks, which is the and then the other one is COVID. So the people reach to the point that we are providing medical care to a person. Medical care or health care has to be provided and built upon around the human being, because the human being is not just a diagnosis. This is all the diseases, all the issue, all the timeline, everything else. And in terms of that, when we went into the integrated healthcare system, so why and what I would like to mention, why does nurse and nursing has such a big strategic value? The first argument is quite simple. If we want to influence on something in the system, right now this session is dedicated to workforce, and the nursing is the most numerous profession. There's around 30 million nurses in the world, and thankfully their number is only growing because challenges are also growing. And around the half of nurses in the health system are nurses. And they're at least 2.5 times bigger in numbers than the doctors. Since if we want to influence the system, influence to the workforce, then they're reaching out to the workforce that are the most. And another important moment that I would just really like to highlight here, I would use capital as the word. I don't like, in terms of nurses and everybody else, to say resources or human resources, because the resources are created so that to take them from somewhere and to use them in a certain, but the capital has to be multiplied and increased. The next argument that we have nurses, and they're reporting, both WHO and International Council of Nurses are saying directly that you have a nurse, please use their potential. And what we can do is a great education to nurses, but they can't do anything for them to use as much as possible. Therefore, what WHO is saying is that we use the professional capacity of nurses to as much as possible give them the ability to be autonomous. And the third important thing for Ukraine is to give this nurse an ability to see their results, for them to be able to see that and their input as well. Right now, it's very much popular. The wording nurse was advanced practice nurse. Our country is setting our foots on that. We want for those nurses to appear in our country as well. From another side, a lot of people are perceiving this as an experiment or a pilot that, okay, we're being tested, the nurse is going to be treating us right now. And on that, I do have two arguments. The first argument, which is not an experiment, this is the world established practice, and right now 62% of the countries are already having those roles. And if you're seeing from the slide, the number of those countries are just growing in numbers. And the second thing, and those medical nurses, masters, and everybody else that are leading with the admission with the doctors together in parallel, there has been an assessment of 18 assessments where those nurses are working, and compare them with the doctors, and then and also, it turns out that medical care that they're providing leads to the same or even better results for the health of the patient. And the patient, we're assessing much higher the level of care that are provided by nurses. And the third thing, when we're speaking about how integrated the healthcare, it's impossible with this, because the patient requires our support. And it's impossible without trust. Then the profession number one was the great Gallup, that the 60% or assessed as the highest, the nurse, and they had most of the ratings. And the level of trust to nurses is higher than to doctors, and this potential has to be used as well. I'm not just showing it off how the health system has developed, and you've probably seen that you started with the specialist care, and then primary medical care, and then community services. What am I trying to allude to? Right now, the medical care is complex. It has very big number of providers, and the patient needs to know where and how to reach out, so there is a need in coordinator. I'm not gonna stop here on too much of the things, and then according to the research where the function of the coordinator has been fulfilled by the nurse, this has led to the decrease in number of hospitalization, the decrease in number of the repeated hospitalization, and the patient were reaching out sooner to the expert, they were sooner to the treatment. And then another argument, and this is that in 2021, the typical patient is most likely a patient of advanced age with chronic conditions. Comorbidity is most likely not one. Right now, it was mentioned the comorbidity again. And then when we're speaking about the chronic diseases or conditions, it's not sufficient just to come to the doctor's office to receive a prescription, get outside, and forget what happened. Chronic conditions and diseases, this is not just the treatment and diagnostics. This is first and foremost the support of. There has to be somebody that everything that's there under the water, all of those activities, somebody has to cover that. And when the patient's going out from the patient from doctor's office, somebody has to take them on. And then the interoperability, and then I represent the Ukrainian Swiss Project Act for Health, and our focus of activity, which is non-communicable diseases. Non-communicable diseases, those are chronic conditions, and chronic conditions, they're not just non-communicable. And then we are foreseeing that this role of the one who's providing the continuity of care and having regular contacts with the patient by training, then to support and that support risk. But this is also in the teams where those nurses are working. It's much better to have the compliance and reducing hospitalization. They demonstrate better experience, and then they're much well versed in their conditions. And right now you're seeing 5 arguments that I mentioned so far on the strategic role of nurses in the build-up of the integrated care. And then I've took them from our today's program. And then you can see and check, those are the words that were more frequent in the program and agenda. And then on the previous speakers and the speakers that had been mentioned before, I'm sure that the workforce, support, coordination, potential, and continuity will be using again. Therefore, nursing is capable of merging the assistant around the human being. And the support, professional recognition of this profession, and for nurses to take part in making changes. Thank you so much for your attention. Thank you so much as well for such an interesting presentation. I think that there's no questions so far. It was very, very good. So you still have 11 seconds to go, so it's, and then, and as those speakers for 2 days, we will be continuing our marathon. And then we will be finishing this presentation part with another presentation, with the presentation of the look of community and what kind of workforce and partnerships to need to for the integrated care to work on this level. So I'll ask the floor, Dmitry Momad, the head of the Department of Family, Social Protection, and Health of Hepatitis community. Thank you so much, and the floor is yours. Thank you so much for the trust and everything else. I'm so grateful to Gunta Zdravitsa for her Ukrainian that's getting better and better. Thank you so much, Maria, and an ambassador of gender equality, and then combating domestic violence, which is the part of my job as well. And also Maria, this is my favorite name, so I have my daughter named Maria. Love you. What I would like to do, I'd like to highlight was the moment Reshetilivka is the well-known Kazakh space and known with the embroidery white over white, and then Reshetiliv there's a part in the Board of Europe or Council of Europe. Reshetiliv was also not well fights for us, but this is one other moment of the recognition of the aggressor, for a 100-year-long aggressor of the Russian Federation over Ukraine. This is the recognition of the Hetman Ukraine, and then in 1740. And we need to understand that Ukraine is a strong country, has been strong throughout the years, and therefore what we would like to tell you, the first and foremost. So we have the population 26,500 people, and this is included internally displaced people. We have internally displaced people a bit more than 1,500, so we perceived everybody from all the regions where we could, and we are taking care of them, and we are providing all kinds of medical support needed, from medical, educational, and social, and everything else. And we are having the primary care, which is important, and then we preserve the secondary care, which was really important for us. And also, I'd just like to have a look at the implementation of integrated care on the level of the communities, taking into point the usage of the new strategy of fighting TB, HIV, viral hepatitis, and also dependencies from the point of view and the needs of the patients. And so the primary care center, which is the point of entry or point of first contact, and so family doctors in that case, and nurses, the previous speaker had mentioned before, and I really like, because what we have to do is objectively reassess the role of nurses, and then to increase their financial load, and then to give them more capacity, because family doctors are in primary care and nurses are present in rural areas, and then they are closer to the patient, closer to the human being, and they are a point of entry, and they're the point of maximal trust, as it was mentioned before, to the patient. And then the central hospital is providing the diagnostics and treatment and consultation for us. But the main aspect is it requires a better access to specialized workforce, because the workforce that went through a lot of training, 7 years or 6 years, and then of training, and then internships and other things, and then that takes a lot of time. And the nurse, they went for training, but they have a higher potential for the people in the population. So, and social services are very much important for the population. All of the social structures and social components, they have always been and will be the grounds for the country to be established. The social workers are helping to fight the people with the different aspects, issues, and everything else. The stigma, documents, transportation, and with the low adherence to treatment that right now that we all have because of the anxiety and feeling that something is not safe, and the needs for protection and everything else. And then primary care centers and everybody else who's working with the people, this is the low point of entry. And then from the rural area just as well. And then the mobile units, mobile teams, they're supposed to be an add-on to the system to train all of the workers and everything else to come into every community to decide upon each and every issue that they are having, and specifically saying the patient pathways and how to fight it.
We clearly understand the role of a family physician, as I mentioned, and a nurse. These are the key roles. A family physician and a nurse are the first entry point, the first contact people who can identify the risks. A family physician and the nurse are coordinating patients' route from the screening to social support and the follow-up. Family physician brings together the medical and social component, because you can come to a family doctor and tell them everything you worry about, and you know that the family physician signed the Hippocratic oaths, and they won't be telling it to anybody. It's like Las Vegas. What happened in Las Vegas stays in Las Vegas. So, the family physician can motivate the treatment, decrease stigma, and support adherence to the therapy. And thanks to the integration, or due to the integration, the constant training shall be conducted. There shall be clear-cut algorithms and support on the side of all the social services and noblest level specialists. Also, I would like to talk to those who create laws. We are a community. Hear us. We want to cooperate. We want to communicate with you actively. We want to have maximum cooperation to solve all the issues and to decrease the challenges on the pathway. Support on the side of the community is the key to success. We need to ensure the continuity of care. Human capital creates the basis for provision of administrative, social, and medical services in the community. We have family physicians, nurses, experts, specialists, hospitals, social workers, administrators. At the very same time, for efficient, integrated care, it's not enough to coordinate the efforts just between the services, but we need to take into account the unified pathway of a patient and to support a patient constantly, and not for them not to be falling out, for a family physician to see that the patient got referred to the services he was being referred to, meaning they have to keep finger on the pulse. Also, we need to reinforce the role of family physician, coordinate a patient's movement along a pathway, strengthening the role of a nurse, and changing the job description of a nurse, having better relationships with the specialized services. The screening sites shall be there in every county, in every rayon. Screening can be done by a librarian or any other person who doesn't have medical background. That's easy. That's really easy. And we all went through this. We value support of the international donors and PATH project, because the methodological assistance, the financial support, the development of the human capital capacity, the information support helps us all develop in the right direction, not to get lost, not to be falling out as the patient who gets lost. We need to stick together. We all understand Ukraine is a big country and we have great potential. We have a lot of people who are ready to change the world. That's very bad that we have war in the country. But now all the countries are looking at us and are borrowing military tactics because just Ukraine can teach the world how to do that. You've seen that Ukraine is winning NATO teams at all the tactical trainings. I'd like to mention that we need to conduct regular training of healthcare providers and social workers. We need to develop the human capital for social support of people facing multiple barriers. It's important to reinforce the access of patients to medicine through telemedicine and online services and bringing medicine closer to the place of residence of clients. Thank you for your attention. Also, I would like to tell you that we need to overcome stigma. We need to have the will to do that. It's very difficult. Sometimes it's difficult to acknowledge the problems. So, we all need to be tolerant towards these people. We need to speak about it aloud all the time for people who had these problems and challenges to not be afraid to recognize that they were stigmatizing others. We need to use the soft force here. I'd like to tell you that the closer Решетилівка is to your heart, the further is the anxiety. There's a small present for you, Miss Gunta, for you, Miss Natalia, and for you, Miss Maria. Well done. You've invested so many efforts. Well, with Решетилівка in your heart, Решетилівka is forever in my heart already. Wow. What's that? Those are T-shirts. Yes, with the hearts. Thank you so much. I'm grateful to you, I'm grateful to everyone, and I'm very grateful to the previous speakers for this today's. Well done. You've invested your heart. Oh, don't steal my bread from me. I'm a moderator here. Okay. Do we have questions? Oh, yes, we have. Mr. Dmitro, Maria says, don't you want to open up the public speeches courses? Just together with you, Miss Maria. No, that's really the question. Well, you are great. I really wanted to become a nurse. No, I have a wife. I'm not speaking about the role plays here. I'm just speaking about children. Oh, no, sorry. What children? That's a nice place. You're a Решетилівка nurse. You are great. Well, I believe all anchors and moderators shall feel fear because there's you. Okay, there are more questions. People have questions to you after your presentation. So, the first one. What's the average age of social workers in your community? Do you conduct screening of psychological condition of these workers to prevent burnout? Well, if they deal with metro, they don't burn out, I believe. Well, you know, all social workers, they work with the supervisors, and we are trying to make it impossible for them to burn out because, well, you understand what category of people we are working with. Now, in times of war, we deal with veterans. Veterans would be a very important category of people. We don't single them out into a separate category, so to say, but we understand that we need to treat them tolerantly, not to ask any redundant questions, treat them respectfully with understanding. So all the social workers are covered with the full-fledged courses and trainings to prevent burnout. Could you give us a few pieces of advice from those courses? I don't want to burn out. What shall be done not to burn out, to be as energized as you are? To be from Reshetilivka. Amazing. You're amazing. And yet another question. Thank you for your presentation. Mr. Dmitro, have Reshetilivka community signed a memorandum on cooperation within the framework of TB-free community? Yes. We looked at the draft memorandum. We start to work on that. Well, it seems to me you will sign it in a moment because you gave this answer. No. Now I would like to tell you that it's underway. We are agreeing. Okay, we trust you. Yeah, we are working on the text. We have a draft text so far, and we are treating it seriously. But now we are trying to clarify certain legal aspects, psychological and social. Yeah, but in Reshetilivka they never burn out, so we decided not to go too deep in these issues. Third question: what screening is conducted by non-healthcare workers? What screening? Okay. So, HIV, hepatitis. Well, who in Reshetilivka does that? You may tell it's not my specialty and I don't know. No, it's a question that shall be addressed to me. Hepatitis, TB, HIV. Obesity as well. It's all conducted. It can be conducted in the library, at the culture houses. How are you? I'm good. Are you good? I'm fine as well. I was thinking, can you help me announce the lunch? Because I won't do it as good as you can. Could you say, dear friends, though you are not from Reshetilivka, I will not leave you hungry. Announce the lunch. Thank you, Miss Maria. May I hug you? Yeah. Thank you for being a great anchor. I believe everyone's angry after her. Hungry after her words. Sorry, but no. You improved my mood. I had some burnout. No. We do not allow you to burn out. I will come to you and get a selfie with you. Dmitro, huge round of applause to you. Dear friends, I announce lunch. 1 hour, and we go back here to properly summarize our forum. We are going to have a few more speakers, and I ask you to eat well, bon appetit, enjoy your meal, and with the words of Dmitro in the heart, with Reshetilivka in the heart, don't allow the burnout reach you. Enjoy your meal.
Так, шановні друзі,
So, dear friends, let's gather together. This is the final line in order to really reinforce everything we've heard, analyze it all, and to dive deeper into yet one issue that is still to be discussed. To the extent possible, everybody who has joined online broadcast, join us again. Everybody who's listening to interpretation, please don't forget to switch on your headsets. We are going to also be subjected to one more survey at the end, but now let's continue. Continuity of care depends not only on the availability of services, but also on whether the necessary information accompanies a person during their transition between providers, programs, and regions. When systems remain disconnected, patients are re-examined, workers duplicate data entry, important results arrive late, and responsibility for further support becomes not really clear. So this is something we are going to discuss this hour. We have three speakers who will help us combine three perspectives: electronic tools of the National Health Service of Ukraine, software information systems of PHC, and daily experience of maintaining and using data at the level of healthcare institution. Don't forget you have an opportunity to ask questions to speakers, and I will voice them out not after every presentation, but then as we have the panel discussion we are going to have after all the three presentations. So use this opportunity. And now I would like to give the floor to Mr. Dmytro Chernysh, Director of Department of Development of Electronic Healthcare System of the National Health Service of Ukraine. The floor is yours. Greetings. Hello, everyone. That's nice to greet you at this excellent event when organizers invited me to talk to you today about electronic healthcare system because I'm responsible for this at the level of the National Health Service of Ukraine. The organizers wanted me to emphasize in what way the data of a client, of a patient, follow their pathway in the healthcare system, and in what way the data exchange is happening between the HCIs, between various systems. So I would like to describe a pathway of a patient from the viewpoint of electronic health system. And in my presentation, I'm going to speak about this system as the national system that contains information about all the patients of Ukraine and information about what medical services they got at various healthcare institutions. So we have a patient, male or female, with a certain need of getting a medical service. This can be prevention, treatment, but a patient, from the viewpoint of electronic health system, gets registered in our system either through family physician or through any other physician or their own account. From the viewpoint of electronic health system, a patient gets registered in the registry that is called Registry of Patients. All the personal information is contained there about citizens of Ukraine, about our patients. As of today, this registry has got more than 34 million entries. More than 34 million Ukrainians as of today are registered in the electronic health system. They have got their account or medical record, and this being the case, they move along the healthcare system. So, if we imagine an ideal pathway, whenever whenever a patient has got a need to get medical services, where they have to go to start with. Okay. To start with, what they have to select for themselves, that's an HCI, healthcare institution of primary level. From the viewpoint of electronic health system, this is an entry in the registry. We preserve information about all the healthcare institutions of the country, about their licenses, about sites of services provision. At the HCI of a primary level, I remind you. Our patients select whom? They select a family physician. From the viewpoint of the system, again, an entry is made. There is the special registry, by the way, where we have information about all the physicians of Ukraine who are using the electronic health system. In the course of the primary interaction, the very first interaction of our patient with the family physician, what is happening? A process of applying for electronic declaration. Actually, majority of the citizens of Ukraine have got electronic declaration with their family physician. Majority have selected their family physician. From the viewpoint of electronic health system, we ensure this functionality. I, as a patient, can sign a declaration with my family physician. Then, in the course of this first interaction, the declaration is signed and the process of provision of medical assistance starts. It can be anything. It can be treatment, prescribing medicines, procedures, diagnostics, etc. All this information is registered by a family physician in the format of an electronic medical record. And this record is the basis for the electronic medical record of a patient. And each and every out of 34 million patients have got their own medical record. From the viewpoint of the system, it's really stored in the form of electronic medical cases. There is appropriate coding used according to state classifiers that are being used at the level of the country. And it really exists in the form of medical records. If our patient needs certain pharmaceutical treatment, for example, physician can create an electronic prescription. Again, this is happening through the system. A patient is getting a certain notification with an electronic prescription. Patient with this e-prescription goes to a drugstore. A drugstore or a pharmacy is also working with the electronic health system. They've got pharmacists who appropriately will issue the medicines, and the patient would get the medicines needed, medicinal products needed. It depends on what kind of need the patient has and what was prescribed by family physician. In the electronic health system, we have such an opportunity. Well, it's not very popular as of today, but maybe 5 years ago it was one of the most important features. If our patient has got COVID or if he or she was vaccinated, based on this registered data, our patient could and can have a COVID certificate. As of today, it's not a very in-demand functionality. Okay, a physician is making a decision that apart from medicines, a patient would need to stay home for some period of time, rest a bit, and our family physician creates a document that is called medical conclusion about the need to have a sick leave. This document is created by a physician and it highlights that this client, this patient, for a certain period of time is not capable of working. After this document is created, we automatically send it to the system of the Pension Fund of Ukraine, where a patient is created an electronic sick leave. Automatically, I highlight. For those patients who need this, who are insured persons, this process is taking place automatically. It's important to understand that we split the medical and the financial component here. A physician is only registering the medical component of this, meaning the period of time when the patient needs to stay home and not go to work. And a financial component will be actually created automatically if in the course of provision of medical assistant physicians decides that a patient should have gotten consultation or some procedures with other specialists, the physician will create an electronic referral. Again, this is a document that will come up to the gadget of our patient as a document, and then our patient, independently or following the recommendation, will select the healthcare institution of specialized medical care. At this specialized HCI, our patient selects a specialist with appropriate qualification, specialization, and the specialized physician will encode all the services, introducing those into the electronic case record of our patient. Again, any actions, any checkups, examinations, procedures provided to the patient are introduced as an electronic entry by the physicians. There's this process. It's applicable just to women, but let us consider that our patient, usually a female patient, and there was a fact of giving birth to a baby based on the records made by a gynecologist, because this record will be entered into the electronic case file. Yet another document is going to be created, a medical document certifying birth. And this document launches the state service that is called electronic baby, or e-малятко. So, the information about the fact of a baby being born is registered in the case record of a patient. There will be the specialized document confirming this, and then this document will go to the Ministry of Justice system, and automatically all the other important documents will be issued to this newborn baby. The baby will be registered. No microphone. Give us 1 second, friends. Something happened to the speaker's mic. Great, thank you. Our patient, especially under current living conditions, may require such services as are in great demand today. And from the viewpoint of electronic health system, when a patient needs getting rehab services, their services are also registered in the electronic health system. This being the case, through the e-referral, our patient can be referred to rehabilitation healthcare institutions, and at this rehab HCIs, they will find rehabilitation specialists, and all their actions and all the rehabilitation services are going to be also registered in the electronic health system. Once again, an electronic patient's history is created. Here you can see actually an electronic pathway of a patient from the viewpoint of electronic health system. Well, this is something the organizers wanted me to highlight and show you in what way these records follow patients and how the patient's clinical record is created. Shall new artifacts emerge here? Yes, they shall, because we've considered quite a simplified pathway, a simple pathway of a patient. We've considered just 3 types of healthcare institutions: primary level, specialized level, and rehab healthcare institutions. But sometimes patients would need visiting other types of healthcare institutions, and their records about this shall be also entered into the system. So this is our task with the colleagues to actually work on all the systems to create all these links with one another, meaning for the information from the institutions where patients are getting medical or somewhat medical assistance to be introduced into the case record of a patient. So, electronic health system is very schematically shown on this slide. We do everything possible for it to be really talking to all the other systems, for it to be interoperable. We will inform you of all the other features. If you have any questions, I will answer those. Thank you. Thank you so much. I repeat that we will ask all your questions after the general panel. And now I would like to give the floor to Mr. Alexander Kurdus, head of the Information Technology Department of the Public Health Center. What's you? No, sorry. Something. Alexander, why are you still sitting? I was thinking maybe I got confused with something. I announced you properly, right? Yeah. Just you didn't move, and I got distracted. Everything's great. Everything works. Say something. 1, 2, 1, 2. Perfect. It's okay. I will start presenting then. Dear colleagues, hello. My presentation is going to be about information systems of a PHC and in what way they behaved and how they felt since the very beginning of the full-scale invasion. For sure, those were huge challenges for the whole healthcare system. And at the very same time, everybody who's dealing with the information resources started living in some parallel reality. There were challenges with cybersecurity, electricity supply. So I would like to tell you the story how we were doing in this regard, and I will highlight our key strategic systems we are trying to take good care of at the level of the country.
In administrating and public health center, there's 3 big systems on the national level. I'll tell you a bit more about each of them. First of all, information systems for socially significant diseases. And the first medical information system before, as this idea came up to be in Ukraine, we started to build it in the 2015. At that time, it was based on the medical electronic records of the patient. That is the foundation from everybody and every system. So it started off as the registry of patient as HIV infection, but right now it fulfills a much wider spectrum of services. And right now I'll tell you more about them. The second system that has a wonderful name, if shortly, which is service management system. So we've developed it and implemented in the conditions of war because there was an acute need and request from the government and the digital accounting in terms of support and preventative services. This is why I'll also tell you a few things about them. And then a strategic system, and I guess the most important system, which is the electronic episurveillance system. Unfortunately, we need to say that in the country where the war is going, the risks for outbreak of communicable diseases are growing, and the decrease and worsening of situation for epidemiology of the country. Therefore, the country has to have the instrument that will be able to help do the data collection, make a correct decision to find those challenges. And so we can start off with the socially significant disease information system. And shortly, let me tell you what is a part of the function. So we started as the registry of patients with HIV infection, but you became more ambitious with the time, and right now they have patients with different nosologies, which is HIV, TB, OST patient, and the patient with the co-infection. And you can see this wider spectrum of functions and a need in the logistics and accounting for medication in Ukraine. Throughout the years, information systems for significant diseases became the only valid data source for planning and procurement, needs assessment of medication and all of those conditions. And so right now it plays an important role. And a big number of reports that are being generated from the system, because it's, and then they're using them in daily life. And this is different changes that are allowing you to understand like how correctly the thing is being prescribed, and then to which extent the patient are receiving care, and to how much the regimens for treatment are being prescribed correctly. And then we are starting to work on the model for forecasting and mapping. This is why I think this is also going to be developed. So a few of the numbers to understand that on the level of the country, this is thousands of countries, and then and the difference between the full-scale invasion. And when they prepared the presentation, the 24th of 2022, and the team of support of the system did not have the question whether we will be working. The question is if we can help the thousands of patients that were moved throughout the countries, and because of the safety situation. And this is not like a metaphor. From 2024 to 2025, there have been hundreds of requests on how to help patients outside of the country or in health facilities. This is why, let me tell you that this was a crisis response, but what's nice is that this system became a great instrument for what it was created for. So to be a great assistant, and then and that worked on the in two countries, and therefore the system is not created for just existing. I described its benefits, but the bigger the data that's being filled, the more data it has, the more useful the system is, because it allows you to make a more comprehensive assessment to how at the level of the country the patients are receiving support, what kind of trend, geographical, demographic, and different changes to build different analytical products, and then make grounded research, and to make managerial decisions that will be in a great way to influence the socially significant diseases. And of course, the value of the system is that it's daily used by thousands of doctors at different requests. They're asking us to improve it. I guess this is the best result that the system started to work correctly and took its place among the doctors that require a modern and easy to use and is it modern, user-friendly of the user instrument that is allowing them to save time and resources while working on a patient. So what else is there? And regarding this information analytical system management of services, this is something new. The country required digitalization and then accounting for services, and then in terms of prevention and support, and it's clear that we've tried to establish a comprehensive system and then to close the matter of the warehouse accounting, because there are a big amount of components of the issuing of the goods and services and everything else. And so the work with the accounting, because this foresees payments for all of that, and then it has to be transparent, and then to make a decision that will help you look to make changes in the paradigms of provision of such services. And then how big of a scale it is from the moment of implementation. We have more than 10 million services provided, more than 4 million conducted meetings, and then and we are moving to the million of unique clients that have been received those services. And the analysis of the data and how correctly they are received by the patient. Why those instruments are so much needed? Because the social workers that are providing those services, they wanted to have a flexible instrument that's working in different conditions, even without internet access, that would allow them to understand by opening their phone or a laptop like how things are working. And then the era of Excel files or paper-based carriers, it has to go back into the past. And after they've entered the information, they're just starting to do their work because they're conducting different analytics. You've seen on reporting, and then you've seen how the warehouse is done and how things are done. Each second, they having access to the real situation on the level of their organization, which is the main request to their instrument. And then on the EPI surveillance system, digitalization and health, this is important, or in episurveillance, because episurveillance is multifaceted. We have started with the most important ones, which is the case collection on the communicable diseases. Almost 600,000 cases has been entered, and then we are starting a routine data collection and using the system on the level of the country. And for that, we are also working on the e-reporting, because when we have in documents the system's producing, and then it does bring a big load on the users, and then the usage of the system has a point only, not just practical, but also to fulfill the legal responsibilities. And you can see that the outbreaks of communicable diseases are being registered in the system, and then therefore the users here are regional centers for disease control and prevention, and their structural subdivisions or affiliates or branches or regional offices or district offices. Then this system is present in every placement. This is more than 110,000 users that are working in a surveillance system every day. And so shortly about the modules, this is not just communicable diseases as of now, all the statistics and information on episurveillance on influenza and acute respiratory syndromes. And then if you remember the COVID times when the whole country was just so looking at a map, was green and everything else, and they were just waiting for a region would get out of the quarantine. And then right now this module, they're also doing the cases of COVID, and so this is not as much needed, but the country needs to have a easy-to-use instrument to track for every case in online version, and then to make those managerial decisions. Let me touch based upon a very small module of occupational diseases and conditions, and from the terms of accounting of the volume and users, this is the very complex one. They having thousands of cases. So let me just explain in this example, like how does the implementation of the system works. This module and digitalization of episurveillance and communicable diseases and everything else is in direction on the European Union and within the accession process of the Ukraine to the EU, and then its function there is valuable for the country. And then Public Health Center within the implementation of this module is cooperating with the State Labor Service, and then we are trying to develop and putting the use of the system into other agencies as well. As an example, as instruments are aligning bridges for connections, and then they are very much useful to get feedback, to understand that your systems and your instruments, not just internal organization is using, but also the agencies that are not connected to you, and this has value. And so I would say take longer to describe our plans. We have multiple plans and of course many challenges. We want to be in line with the regulation of the European Union and personalized data, and then we put some steps, but not. And we wanted to highlight about this. We wanted to highlight that the system for public health center can not interact in isolation. And Mitra mentioned today that we really started to do the work in integration, and so we do understand that the e-health system is a key and strategic data source in the level of the country. Therefore, the building of the high-quality, full and operational integrations with the e-health system is our key objective for the future. And I think that after the implementation, the goodness from that will be felt by everybody, because this is done for the patient, because the patient level of the country, they have to be sure that all the information that is being provided, given and assessed and stored in one place in electronic medical records. And when there is a question on the provision of quality medical care, and the doctor needs to have all the needed access, all the needed information on the patient, and yada yada. The right part of the slide is telling us that we are building on the public health center also an ecosystem when all of the branches of care that we are responsible for, and also experts of IP surveillance, and then they are exchanging the information in their and then our key objective is the development of analytical capability of using this by control centers in the regions, and then we are trying to hear them and to build a tight interactions, and therefore our plans and objectives on the implementation on this slide. Thank you so much for your attention. I think in the panel discussion I can answer your question. Thank you so much, Alexander. Another presentation before the panel discussion from Ludmila Vinnik, a medical statistics. No, I can't make a mistake. So, medical statistician, administrator of Chernihiv Regional Clinical Hospital, and then which kind of practical decision and information support have already worked and been scaled up. This is what your presentation will be touching based upon. Yes, greetings, dear colleagues, dear present colleagues. I'm not going to take a lot of your time. My previous speakers have openly mentioned how does the electronic health system is working, what kind of perspectives for the future it has, and I would just like to share with you not as much of the theory, but as the fact that daily we're meeting things in their line of work. Chernihiv Regional Hospital. This is multi-profile, supercluster hospital between our hospital and National Health Service of Ukraine. We made a contract on provision of medical services to the population on the program for medical guarantees. We are providing services and 21 package of services. Among those packages, there's also a package on diagnostics and treatment of TB, and the package on diagnostics and treatment and support of people with HIV infection. When we are speaking about the patient pathway, we are mostly saying that there has to be a continuity of care. Daily, the doctors of our facility are establishing and working in the e-health system and are creating a lot of medical records. And when the patient are coming from one stage of treatment to another, from one doctor to another, from one health facility to another, there has to be medical information moving along the way. From the next slide, about the scale. During the 2025, just for the medical personnel of our facilities, have created more than 1.5 million medical records concerning 71,000 patients. TB doctors, infectious diseases doctors in the area of work that we have processed right now, they have created almost 103,000 electronic records for 3,800 patients. But by pediatrician or TB doctors created 13,000 e-referrals, but overall in the hospital, 240,000 e-referrals have been created. From those referrals, 90% has been fulfilled. Also, the numbers that I've presented on this slide has been taken from the analytical dashboards of National Health Service of Ukraine. What for I'm putting these numbers up for the number of medical services, you can't provide an assessment of quality of services provided, but I would really like for you to understand what is the scale of medical information is already present in the system, and it is what kind of scale we're working here as well. So we can't really say that the information is just not there. The information is there, and the information is plentiful, but whether it was accessible to every participant of the way. And then let's just have a look at the example of our health facility. For treatment of patient with TB, they might be within their facility up to 7 separate units or departments. This can be consultation, diagnostics, inpatient, and others as well. In our house facility, the movement of medical information, what I mean is that in our electronic way, mostly aligned and harmonized. All the doctors are having automated working places, most likely meaning computer nurses are also provided with the automated working stations, and then in the sufficient numbers. Most of the primary medical accounting information is being done electronically and not paper-based, but unfortunately the state at which our country is in does not allow us to say no to having paper-based documentation. So our house facility, before transferring to having those forms electronically, is almost ready. And here it's all clear. For example, a patient or the doctor from ambulatory admission or the doctor for an inpatient, they're doing in the electronic patient records or an ambulatory card like a prescription to something, and then another doctor, the specialist to whom this is addressed, they're seeing this his account, this referral, they registers the results there of testing done or a consultation, and those results automatically gets to the electronic ambulatory card or electronic patient history. And so here I guess it's clear. And then I would also like to say that most of doctors in our house facility are working in one medical information system, but the doctor of infectious diseases and pediatrician are working also in additional information system of the IS, socially significant diseases, which also creates an additional load on them. When the patient leaves the treatment on the specialist care, and then they're moving under the support of the family doctor, and here, and then does the family doctor seeing this from the house system, then the medical information system that has been created in our house facility. The information that has been put through the regular medical information system, I'm saying regular, not to say the name of the system that you're working with. Family doctor, in most of the cases, they're seeing this information in a full amount and volume, but they don't have access to information that has been created into the information system, the socially significant diseases. And then there is the question of The information is there, it's sufficient, but it's not accessible for the next participant of the clinical pathway, which means that referring to health facilities, and then the data from the information system social significant diseases are also not accessible to other doctors or specialists, apart from pediatrician, infectious disease doctor, and I also think that this is an issue. And then I think that the most complex and the worst situation is going in the movement of the information from the health facility to other institution, and then, for example, CDCPs itself. As of today, the medical information to such health facility is incoming only paper-based. The best option, this information is being transferred because of the electronic emails, essentially. So I think as of today, this is not the best way forward. I'm not even saying about the general organization and NGOs or charitable organization. And since we have the issue with the transfer of the information, then there is an issue what kind of information has to move. And then with the patient, this doesn't only mean for conditions, diseases that we were looking at before. I think that the next participant of the process doesn't really need to know all of the patient history for that patient and all the archive for the medical information. The next participant of the process needs to have an accessible information so that he can rapidly make a clinical decision, so that you need to understand what specifically is happening right now with the patient, what was done to a patient, what was prescribed to the patient, and what was the specialist has to do in future with that patient. And so conditionally we think that this kind of information can be separated into 6 areas. The first is the issue, so confirmed diagnosis or suspicion for a disease. The second one, the key assessment results, not all of the results of all of the testing that somewhere ever done this has been conducted to the patient. And then specifically the key results for testing that are influencing the future clinical decision. And the third thing, what kind of treatment has been conducted and what was prescribed. The thing number 4, what has to be done in the future. The point number 5, who's responsible for that. So there has to be, and then the 6 is there a chance to lose the patient from the pathway? And if they didn't come to the visit and they're not going for the contact. It's important, and for the minimal set of information that has to move with the patient and was aligned between the services, can we transfer this information technically? And I think that we can. And we see this in an example of a hospital where there is a movement of medical information happening and it's successful. So what can we do? All the facilities are working from the medical information system, and medical electronic records are created by each and every one of them. There's not just the record, this is real-time testing, prescription, procedures provided, consultation, or a treated case in patient condition. All of the data gets to eHealth system, it's clear, it's there, and then this is already working. But there are other systems like information systems for truly significant diseases, and then that's not yet integrated to the eHealth system. It's not yet integrated to the eHealth system, but we've started from our previous speakers that the work on that is being done, and we will be hoping that in the nearest future this will be working together. So what for is this important? Because the pediatricians, they're putting the medical information to the information system, socially significant diseases, and then a lot of useful information, and then but at the same time they're overlapping the entry of information into the medical information system where all the doctors are working in, which creates an additional load. So if the patient is going from one level to another, and then the next expert is not seeing the whole picture or the whole medical information that for the continuation of this case, so what do? Once again, they're entering the data on the patient into his additional information system, so that there is this discrepancy in medical information and digital environment present, but you have to again on the next stage to have to be entered additionally. So this leads to overlapping of the works, and then duplication. There's always issue of mistakes, both human and technical. It creates an additional load for the doctor, because they are once time again they need to create and creates the patient history. And also for the next doctor might not be able to see the results of testing done by their information system, even though this kind of testing has been conducted and they have additionally prescribed this kind of testing so far, and this requires then unjust financial losses. And then what you need to do for the interoperability of care, and this is needed to be concerned what kind of data are mandatory for the system, who's supposed to take them in, who's checking them, who's updating, who is responsible for the next stage, and what is happening if this stage didn't really happen. And so this is important only in the case where if there is an aligned minimal list of medical information that has to be exchanged and be moving and following the patient, when there is a responsible person for entering the data and for quality of the information, and then will be conducted the data exchange between electronic health records and systems. So I guess for an improvement of the continuity of care, we need to have that the needed information would be entered only once, would be accessible to any following expert, and will be clear for decision-making process. Thank you so much. Thank you so much. Thank you so much, Ludmila. And then we'll ask you to get done because we are updating the stage for our panel discussion. And let me remind you that all three previous speakers will be asked to be present on the table and on the stage. And this panel, and opposed to these, has required the biggest number of questions. So get ready. There's a lot of them. And then we didn't have that much, not tens of questions, but I'm seeing that your appearance here has caused a vast interest. Therefore, Alexander, others, Dmitro, and Ludmila to join your seats. Please take your microphones. I have a table and everything else, and we'll start going one by one, and then we'll see on the evolution of the topics. This is the question from everybody who's watching us and present in the call. Metro, what and how do you see an electronic medical space for working and processing for a nurse? And is any steps are done for extend the functionality of that medical space?
Very good and relevant question. I see a medical nurse as a full-fledged participant, member of the team of medical aid provision, and from the viewpoint of electronic tools and in general from the healthcare viewpoint. Now we speak about expanding the job description of a medical nurse. That's a good topic, and we are having very fruitful discussions with the professional community, and this is actually very important to identify what we need by expanding the mandate. What I see, somehow this is understood as to make it so that a medical nurse will deal with the documentation instead of a physician. So, I believe expanding functionality mandate would be to grant a medical nurse with some new rights for her to be able to perform more functions as regards patient. And so, the electronic systems would be just a necessary tool. So, we need to have this frank dialogue and based on its outcomes, decide what we can offer to a medical nurse for them to be doing on their own. And if to speak about some solutions already developed, that could be, for example, issuance of e-prescriptions for certain drugs, then opportunity to create e-referrals for certain services, not all the services, but just some of those where a nurse can do this. But this is again subject to discussion. So far, there were no decisions made. So, who asked this question, who's in the room, please join our discussions. They are taking place at various platforms like AMZU, Association of Family Medicine, platform at the basis of MOH. Really join us and provide us with your proposals. We will implement it all. So these platforms are being monitored and they are actively functioning, right? Yes, sure, they are functioning really actively, and the medical community is represented. There are representatives of the state, representatives of those who are going to implement it all, the medical community. So that's a dialogue that shall give birth to an efficient solution. Not just we talked and we issued some protocols and went home, no. So, again, what's important here, and I emphasize that electronic tools in this case, I don't want to diminish my work or work of my community, of my team, but we are just a tool. We implement it in such a way as dictated by the mandates and rules. Thank you. Yet another question to you, speaking about electronic health records and the problem with the private physicians. Their medical records can rarely be found in the system. What is it related to? I confirm that this problem exists. And the use of electronic health system is an obligation of everybody who's got the license to perform medical practice, to provide medical services. And this is a stick and carrot issue. Don't perceive me wrong. I resort to the representatives of the private healthcare institutions. But you've never been used a stick to. When there's no real responsibility for not following the rule, well, human nature is such that they don't mandatorily do that. So the rule is there, and still the private medical institutions are not following that rule, and there are no sanctions. We need to have a mechanism of control, a mechanism of sanctions imposition, and for sure we don't want to start with these mechanisms, but carrots are no longer working here somehow with the private healthcare institutions. Thank you. Alexander, a question to you. Do you have statistics of incidence and prevalence? Sure. This is one of the key indicators we deal with, especially if we speak about communicable diseases. There are two components here. There's official statistics, and there are reporting forms that are regulated by the orders of the ministry. But at the very same time, they might have different variations, and we try to prepare some analytical materials as well that are highlighted at the website or in the form of a dashboard to be more visually user-friendly, with the geographical split up, with the age disaggregation based on various therapeutic areas. So yeah, for sure, this is constantly done. Now, a range of questions to you, and I'm very sorry because I don't really understand what I'm going to ask you about. How many laboratories are using the laboratory module ES, and whether the lab module is being used in the regional CDCs? I would like to answer that I don't understand a thing here as well, but unfortunately I do. I understand it all. That's a very interesting question, by the way, because laboratory component from the viewpoint of epidemiological surveillance and monitoring is one of the things that needs to be digitalized. In Ukraine, we have laboratory information systems, and this would be the tools that allow digitalizing business processes at the level of the laboratory. Laboratory information systems are being used by big network laboratories in the state sector as well. Laboratory system is, actually speaking, a medical information system that has to report a set of data to the electronic health system. Now, coming back to the question, the informational system of the socially significant diseases were integrated a lab component. So the interface was created, and I can't tell you that we have some regulatory mandates, or as Metro is saying, that we can resort to the registry and get a stick rather than a carrot. But we see some progress in terms of connecting this or involving these laboratories. It's about 50 laboratories, and the key would be the HIV and TB laboratories. We started actively involving also laboratories of regional CDCs, but it's worth mentioning that they are already using for an extensive period of time their laboratory systems. We don't want to interrupt with this, but we would like to integrate the data streams into our systems in order to create a unified electronic repository of data about a patient, and laboratory components will play a key role. I hope I answered. Thank you. I will continue, if I may, with this quest of my lack of intelligence, and I will voice out the next question. Do you plan to have exchange of information on HIV testing between the institutions I've mentioned? Okay, I got the first institution. It's difficult to understand what's the first institution you refer to. I was showing you the ECHO system. Maybe I didn't go in too many details, but in the context of HIV infection, the testing data is one of the key steps of the cascade when you understand how many people were tested, what is the share of the confirmations, confirmed cases. So these are the basic indicators that allow making strategic decisions at the level of the country. Unfortunately, my colleague in her presentation confirmed that actually the Information Systems Department of PHC collecting information about such patients. Well, for sure, any site in Ukraine can be testing patients for HIV, and this information will still be introduced into electronic health system. Well, we cannot actually integrate our system everywhere because it will be, one more system to overload physicians, but we strongly hope that in the nearest future, I actually will answer that yes, we did it, and that's success. That's interesting. I have a feeling that I'm asking you encoded questions, and you answer me with a human language, and moreover, you understand me. Well, I created half of it, and that is why I understand it. No, these are anonymous questions from the room. I'm not giving up then. E-blood program is going to deal with Ms. Apit or LIMS? Yeah, you start encoding your questions. Have a look. I can't give you an exhaustive answer because PHC is not an organization that is responsible for the e-blood system at the level of the country. And this system functions and its tasks are clear. That's actually having the lists of potential suppliers of blood components, and as any national scale system, it cannot be existing in silo, be isolated. It shall have certain interoperability with an electronic health system, but maybe some cases that will be registered at the level of e-blood are valuable, and they will launch the mechanisms of epidemiological investigations at the level of the country. So I have quite a mixed answer. This question is going to be integrated into the electronic health system. We have lively discussions at the level of several organizations, including with the National Health Service of Ukraine and PHC. But we do not exclude the data from this system will be used in the area of epidemiological surveillance. Thank you so much, Ms. Lyudmila. Just one question to you. Why you are so sure that confidential information about HIV status has to be accessible to all the healthcare providers at the medical information system? Yeah, I'm sure, because it's already stipulated by the rules of medical information system, electronic health system. If this information is in the health electronic system, it doesn't mean that anyone will have free access to it. A specialist who will need this information shall get an authorization from a patient to look at this data. And it doesn't matter whether a patient has got an HIV status or not. In general, whenever any action was taking place, for example, the testing proper, regardless of its findings, without authorization of a patient, consent from a patient, a healthcare provider will not even have a look at the fact of this action. Yeah, I would like to add and confirm, really, for there to be no such myth. In the electronic health system, there's the group of diagnosis related to HIV/AIDS, so there are stricter rules of access. Really, this is never the case whenever any physician just enters and looks at the information that there was the fact of HIV testing, or there is the positive confirmed HIV case. No, there shall be consent of a patient. So there will be a code sent to the phone number of a patient. Patient gives this code to the doctor, and then doctor will get access to this part of a case record of a patient. Then I have a question to you, Mr. Dmitro. Maybe it's related to this. There's problem with access to patients' data on the side of HCI if they work with various systems. So sometimes a physician might not see the test results if these tests were run in the other healthcare institutions. Will there be some changes that will allow physicians access to exams findings regardless of the system, just to improve the pathway? Well, that's a question which is being periodically raised. I was sitting here listening to my colleagues, texting my other colleagues. We, on our side, are checking whether the processes are working properly, correctly. Yeah, it happens that sometimes the processes stop working properly. We will try dealing with this. But in majority of cases, I personally checked. This would be sometimes lack of knowledge how to verify this information. This is not that the information is not available. We got used to press this tab and this tab, but somehow nobody taught us to click this third tab, and we don't do this. Well, I'm just explaining in a primitive way, but this information is really accessible, but you just need to know how to get it. So we are trying to teach people how to do this and to teach them, to show them how to get access to the information about the previous service. May I add? Yeah. I would like to confirm what was mentioned by Mr. Dmytro based on my practical experience. Physicians of our institution, and not just our institution, can really have a look at any medical information if the patient allows. That was introduced into the system by physicians of other healthcare institutions, but there shall, well, the physician who needs to learn this information must be covered with appropriate training. Really, healthcare providers sometimes do not know how to use all these digital tools, all these functions, and how to get hold of this information. But it's there, and it works 100%. I would like to add, maybe this doesn't pertain to this issue specifically, but when our physicians need to have a look at patient's case record, what kind of treatment was conducted previously, or have a look at some diagnostic test findings, we feel bad when we open medical record and there, apart from code of patient's consultation, apart from ICD code, there's nothing. No, I believe, and it's just not me who believes that, we believe that there's no use of such a record. It's not valuable at all. And the same pertains to lab tests. The fact of the test being run is registered. You open it up and it just says the test was run. That's it. That's a problem. I believe that healthcare providers shall be trained how to work with electronic health system, explain it all to healthcare workers, why it functions, and unfortunately a lot of physicians are perceiving their work with the medical information system as the ground to be paid by the National Health Service. They don't understand that we create a medical record of a patient. Who shall train them? Well, at our institution, we have a special department, and it's called the Software and Medical Statistics Department, and it is responsible for the functioning of medical information system, or MIS, in our healthcare institution. At our institution, we conduct training of our employees, individual ones, and group training. We conduct the technical support, and we help our healthcare workers whenever they have some problems with working in medical information systems. Dmytro, yet another question to you. A family physician refers the patient to other physician. So a patient has to find an opportunity to meet that doctor. But as the practice shows, sometimes it's a challenge to find that specialized doctor. Sometimes there are 10 minutes to get a consultation, and then it closes, and you have to be waiting for seeing this doctor the next month. In the country, there's no state centralized waiting list to get to some doctor, and I believe this is good. because responsibility for organizing the provision of medical services and how to get to a certain doctor would lie on the shoulders of the managers of each and every healthcare institution. So it all depends on the work of managers, leaders of healthcare institutions. So actually, speaking about the practice, to, in a centralized manner, somehow identify who can go to which doctor would be a worse idea. And, following this very question that sometimes the line is too long, the slots do not open up. Actually speaking, there are plenty of positive cases when you can find a specialized doctor for tomorrow, a day after tomorrow. We need to have a look at these best practices and follow these successful examples. How to organize the line for certain service. Not every institution is even giving an opportunity to patients to actually call and ask to see the doctor or do this in an online format. Sometimes you have to go to the HCI. If you think that we need to have a centralized database and it's going to be a magical pill, no, it will create more problems and a patient would just lose access to medical services. Really? That sounds serious. Yeah. Actually, plenty of countries made this mistake, and speaking about such a large-scale country as Ukraine. You always take into account that Ukraine is one of the biggest countries of Europe. We have plenty of people. Our population is huge, even regardless of the war. Plenty of Ukrainian citizens left abroad, but nevertheless, in Ukraine, we have around 30 million citizens. That's a big country. And to make them in a centralized manner to be finding some slots, well, for 80 years we've been building a centralized country and it failed, and thanks God we are no longer in this centralized country. Thank you, dear friends. We are wrapping up this panel now. I see you are very interested in this topic. Thank you so much, dear speakers. Thank you. Please take your seats in the room, and we are going to summarize, because we all want this forum to end up not just with a list of problems. Well, for sure, we need to voice out good ideas, prospects, way to solve some challenges. For each and every one of us, it's very important to develop the further steps. What plans are the priority ones? Who needs to implement them, and in what way we can continue? I would like to invite Volodymyr Kurpita, Director General of PHC. Yesterday he was opening this forum and he is closing it now. And please take the chairs away from the stage if possible. I don't remember who was saying this already. I don't have a presentation.
Progress working together is success. Познайомитися, зустрітися.
To meet together, that's the beginning. To support this, it's a progress, and working together, that's already a success. I believe we are at the stage of supporting each other, keeping together, because this is not the first time that we discuss integration, and I'm very happy that we've managed to bring all of you together. And unlike some monothematic meetings, these 2 days were really versatile. It was very interesting to listen to the representatives of the central level, regions, small communities, bigger cities, and speaking about how to organize it all in practice. I believe that the key conclusion of this 2 days of forum would be that it confirmed what we started thinking about separately. Every system works well, but a patient can get lost when they move in between all those systems, and I believe this is a very good start on understanding how to work, what to emphasize. There are plenty of good tools. We spoke about data, we spoke about tools. We need to get concentrated on two things. We don't need a universal soldier, and that's the key message. But we have to understand that every employee, regardless of the system, of the level they work at, we need to understand where to refer a patient. Yet another good conclusion for me, a patient can be lost between the elements, and we need to understand who can be a coordinator. And there were plenty of proposals that this can be representatives of civil society organizations, NGOs, nurses, representatives of the community. We need to think who this might be, in what way to stipulate this. And the third, the most important issue would be the funding one, because the systems keep on being funded vertically, and the social services, the medical services. And these issues of coordination are not being funded. And in the conditions of the war, we need to understand how to ensure this. Potentially, this can be the projects that are being supported by donors, and we need to think about a model that can be passed on to the ownership of the state later on, showing that thanks to this coordination, we have successes, results, achievements, and I believe actually, we had a broadcast. You can have a look and watch this forum again on YouTube, at Facebook, and we decided to really shape up the key areas of the future activities in order to develop a roadmap. And I believe that next year, I believe we can get together again, not to speak just about the problems, but discuss what has changed since the most recent forum. On our side, we would look for opportunity to conduct such a forum. And we strongly hope that the project will help us coping, because we passed through a difficult process of preparation, and we strongly hope that you will still be very interested in this forum and those results that were presented to you. And to wrap it up, I would like to express my gratitude to everybody who joined, who were organizing this forum. I would like to express my gratitude to PASS project for really actively preparing, developing agenda, and you organized it perfectly well, and we all stayed here in safety, and regardless of yesterday, today it was calmer, sure, but yeah, it was arranged on the highest possible level. Those who came here, those who came one day before and lived through that difficult night in Kyiv, maybe it was unexpected for you. I'm not saying this was a unique situation, and unfortunately I believe you are subjected to this air raid alerts and explosions more often than needed. I would like to express my gratitude to PHC for the soul you've invested in the story of imaginary Andriy we were all telling together at the very beginning. And I would like to express my gratitude to our moderator, Masha. Without you, this would not be possible. And I'm grateful to our interpreters and technical specialists who helped us conducting this forum. Maria, the floor goes to you. Thank you. Thank you so much.
From the organizing side, I would like to say thank you for your presentation, support for the forum. It's really nice. Dear friends, and we have shown a wonderful activity, wonderful examples with the QR codes and the questioning. So right now, an important question for us, which is your feedback overall. Then before I'll ask you to join under the finale, since I'll say goodbye to everybody to run through that again. Scan the QR code in your pages. And then on the platform or on the web page of the nationalwebforum.com.ua. And for us, it's important to get your answers and ideas and opinions. And so after the forum, what do you think of our audience? What has to happen as the main priority for the integrated services? And then the partnerships, coordination, continuity, interaction, respect, and then trust, accessibility, patient pathway, resources, quality, teamwork, management, and then results, human-oriented approach, and then system-wide communication, effectiveness, sustainability, decisions, solutions, or multidisciplinarity. And then you have 60 seconds, so please pick, in your opinion, priorities to everything mentioned so far, for all the important factors that are on the support for the patient and on the your line of work. That's not simple. So after everything analyzed, maybe opinions have changed, maybe there are new reasons for analysis and assessment, and then we're asking you for the past 10 seconds to decide upon, so that we would be able to have a look at your generalizations, and then you'll do this yourselves. You'll be discussing with the colleagues, and then the topics that are there. This is the portion of our life of the people that are without you cannot really finish, and then the results are on the screen, and then what we're seeing is the highlighted the word partners, human-centered approach, which is the great thing altogether, multidisciplinarity, where we can get from there, and then and you can see for yourselves the answers are 41 answers. This is why this is the assessment on the ones who stay till the end of the day 2 of the forum. I would like to say thank you to you, thank you to all the presenters, thank you to all the participants, thank you so much for a wonderful and warm atmosphere, such a working atmosphere, but humane. Thank you for your knowledge, your line of work, for being here despite the complex 2 days. I would also like to say thank you to for the initiative of making this forum, and then Ministry of Health of Ukraine, National Health Service of Ukraine, Public Health Center, Ministry of Health of Ukraine. I would like to say thank you to our international partners, regional and local teams, NGOs and others for an active participation. And thank you to the gratitude for the U.S. government for funding this forum path, and then support of efforts combating TB in Ukraine, for the organizational and technical support and the coordination and the full logistics support. And then thank you so much for whoever's provided the ability to provide this forum. The most important part is to preserve our joint responsibility, our interest in the result, and the continuation of work after the forum. So I think that you can do this and understand this yourself. I would like for us to meet again I wish for myself that as well. I think I became smarter. And more aware and knowledgeable. And this topic, I'll have something to talk to, remind women that are my subscribers and followers. And I'll put a few things on that, all the important topics that they're here that has to be shared in masses. So I'm asking for everybody who took their headphones, please give them back, because you're not gonna give your interpreters to your homes, and please give them back. And so I welcome you to the coffee break for snacks, other things to talk to make pictures, and to have a wonderful experience, and then coming home with ease. And thank you so much for preserving health of Ukrainians. Thank you so much.